Well, good afternoon or good morning, depending on where you happen to be, and welcome to this public workshop on challenges and opportunities for REMS integration, innovation, and modernization. I'm Mark McClellan. I'm the director of the Duke-Margolis Center for Health Policy, and we are convening this workshop under a cooperative agreement with the U.S. Food and Drug Administration. The workshop follows several previous Margolis FDA workshops, including one held in October of last year and one in April of 2022, which considered the elements of certain risk evaluation and management and mitigation strategies, REMS strategies, particularly education offered to prescribers under the opioid analgesic REMS program. Today, we're shifting our focus away from the content of the REMS programs and to the ways that prescribers, pharmacists, and patients and the health systems that they're working within can fulfill the requirements associated with REMS programs. But even though we're shifting the focus here today, I want to emphasize that our work is still on the general theme of how can we, through these efforts, consistently work to ensure that REMS programs function as intended with minimal burden and with optimal benefits for patients, as well as functional approaches for those who prescribe, dispense REMS drugs. REMS programs and their associated requirements are designed to support the safe use of medications and ensure that the benefits of those medications outweigh the risks. But since completion of REMS requirements has often been done outside of standard clinical workflows, they can create burdens on prescribers and pharmacists and patients and lead to delays or barriers to needed medication access. So as part of ongoing efforts to modernize and optimize REMS systems, FDA has contracted with the MITRE Corporation to develop a proof of concept prototype that will allow certain REMS activities to be integrated across all of these stakeholders: pharmacists, REMS administrators, prescribers, health systems, and patients, with the goal of reducing the burden of REMS implementation and improving patient outcomes by integrating REMS into clinical workflows and enhancing the coordination of REMS requirements with the implementation of standard health information technologies. Enabling healthcare providers to fulfill REMS requirements through their standard workflows not only could reduce burden, but also provide more timely and safe medication access for patients. So ultimately, this effort is, again, around that same goal of improving patient access, ensuring patients don't face delays in getting their medications or gaps in treatments, while appropriately addressing the safety issues involved in the medication use. So that's our overall goal. On the next slide, I want to review our workshop agenda. We're going to start with opening remarks from Marta Sokolowska, the Deputy Center Director for Substance Use and Behavioral Health and FDA Center for Drug Evaluation and Research, CDER. We'll then hear presentations from members of the FDA and MITRE project teams who have been involved in developing the proof of concept prototype. This is going to include a recorded demonstration of the prototype's core functions, which hopefully will give everyone a clear understanding of how this approach is intended to integrate REMS requirements into clinical workflows and ultimately streamline the process of using REMS for prescribers, pharmacists, and patients. And then with that context in mind, we're going to move on to a series of panel discussions in which we'll consider how the prototype approach could work for each of the key stakeholders involved: prescribers, pharmacists, health systems, and especially patients. In fact, each of these panel discussions is going to include a patient advocate to keep these discussions grounded in the patient experience and the focus on timely and safe access to medications. Finally, we're going to wrap up with a bigger picture discussion on implementation and considerations for next steps, exploring, based in part on the discussion today, what may need to be done to encourage adoption of the intended approach here, making sure this proof of concept prototype really does work in practice, what implications it might have for REMS systems in the longer term, and what further steps are needed to help optimize REMS use through better integration of REMS programs into clinical workflows and electronic standard electronic data systems. Before we get started, I want to turn on the next slide, I think, to the Margolis Center for Health Policy Statement of Independence. We honor our tradition of academic independence on behalf of our faculty, scholars, and research analysts. Neither Duke nor the Margolis Center take partisan positions, but we want to make sure everybody here is free to speak their minds and express their opinion on important issues. This conversation today is supported through the cooperative agreement we have with the FDA, as I mentioned before. It is not a federal advisory committee. We will not be voting or making consensus recommendations. It'll be a success if we have that frank discussion of how to move forward on these issues and make sure that we have a lot of perspectives represented and a lot of follow-up on points raised as well. I also want to disclose that I'm an independent director on the boards of Cigna, Alignment Healthcare, Johnson & Johnson, and Prognom IQ. I also co-chair the guiding committee for the Healthcare Payment Learning and Action Network and receive advisory fees from Arsenal Capital Partners, Blackstone Life Sciences, and MITRE. But also like to remind our speakers and panelists to include any relevant disclosures or potential conflicts of interest in their opening comments as well. Now, just one more slide with some virtual meeting reminders before we get started. We do want to include all of you to contribute to the meeting through the Zoom Q&A function. Should be a button at the bottom of your window, hopefully familiar to everyone by this point. We want and FDA wants to hear feedback, questions, additional comments. So please don't hesitate to submit those. We're going to try to bring some of these audience questions directly into our panel discussions, time permitting. And also some of our presenters and panelists may also be able to respond directly via the Q&A function as well. We are recording this meeting. We'll be posting the recording on the Duke-Margolis website for future reference. And then before we begin, just a reminder that the scope of the workshop is on innovative approaches, and particularly this proof of concept model for integrating REMS requirements that we're going to hear about in more detail in the presentations that are going to follow me. There are certainly broader discussions that we need to continue to have on the content of REMS requirements for a variety of drugs. But today, the focus is really on this proof of concept prototype and the more general issue of how do we integrate REMS requirements as efficiently as possible into clinical workflows, the least burden, the most intended effect, again, of the goals of this program of assuring safe and appropriate access for medications. Now, with that, I'm very pleased to introduce Dr. Marta Sokolowska, who's the Deputy Center Director for Substance Abuse and Behavioral Health at CEDAR, for her opening comments. Marta, thanks for joining today.
Well, good afternoon, and thank you very much for the introduction and opening remarks. I would like to welcome you to this meeting to discuss challenges and opportunities for REMS integration, innovation, and modernization. I would like also to thank our invited speakers and panelists, the Duke-Margolis Center for Public Health Policy, and my FDA colleagues for your work in putting together today's meeting. Next slide, please. FDA can require a risk evaluation and mitigation strategy, REMS, to ensure that the benefits of certain drugs outweigh the risks. REMS programs enables drugs that treat serious medical conditions to be approved or to remain approved that otherwise would not be available. Some REMS require that healthcare professionals and pharmacies be specially certified to prescribe and dispense, respectively, a drug that is the subject of a REMS. Additionally, some REMS require that patients be in registry. These features, known as elements to assure safe use, require efficient communication between healthcare professional and the pharmacy. However, the current REMS systems are not always integrated into either clinical or pharmacy practice systems. Implementations of the REMS systems can cause burden and, in some cases, can lead to problems of medication access and, consequently, suboptimal health outcomes. While today's meeting actually is the third meeting in the series of meetings dedicated to re-examining mandatory opioid prescriber education, this meeting discussion has implications for REMS beyond opioid prescriber education. To recap, in collaboration with Duke-Margolis, we held 2 public workshops in October of 21 and in April of 2022. The first meeting focused on the need for mandatory prescriber education, while the second discussed the content of such an education programs. These efforts are part of FDA's overdose prevention framework. Neither of these meetings discussed the challenges with implementing such a REMS programs. Next slide, please. There have been challenges associated with implementing different REMS across therapeutic areas, not just opioid analgesics, leading to significant burden and suboptimal medication access and health outcomes. There is a timely opportunity to leverage health information technology to modernize REMS through standardization and integration to clinical flow. Today's meeting will discuss how REMS system can be integrated into clinical and pharmacy systems. Because REMS integration is a system-wide issue, it's not limited to single therapeutic area or a single drug class. Our panelists today represent a wide range of specialties. Next slide, please. Increasingly, the healthcare system is adopting and using HL7 fast healthcare interoperability resources data standards to advance health data exchange and use in response to drivers such as the 21st Century Cures Act interoperability rules. Contemporary research is informing the use of standards and health information technology to improve the use of real-world data for drug safety effectiveness evaluation and safety surveillance, enable clinical education and decision support of the point of care, at the point of care, streamlining prior authorization and strengthen program evaluation. Standard-based health information technology approaches align with FDA's regulatory science priorities, including optimizing use of real-world evidence, empowering patients, and advancing digital health technologies. They also align with FDA overdose prevention strategy, including the ability to integrate education to workflow and in the future support prescribers' use at point of care. Next slide, please. In general, REMS implementation is a manual process and not well integrated into prescriber or pharmacist workflow. This can lead to delays in patients accessing the REMS drugs in a timely manner and suboptimal patient outcomes. The lack of standardized data makes it difficult to share and integrate data and to get timely feedback. Use of data standard and contemporary health information technology can lead to a more automated and less burdensome REMS ecosystem. REMS can be integrated into clinical workflow. Patients would be able to complete the REMS requirements through the patient's EHR portal or via an app. There would be higher quality standardized data for more timely feedback and robust evaluation. Due to reduced friction in exchanging REMS data, patients could achieve more timely access to the safe use of a medication. Next slide, please. Through its work with MITRE and an open community of stakeholders, FDA is championing a use case to integrate a REMS integration prototype. The prototype is designed to demonstrate the art of the possible, to leverage data standard and technologies to demonstrate how REMS can be integrated into the healthcare system, consists of open source code that can be used to run demos of REMS stakeholders' workflow integrations. We ask prescribers, pharmacists, patients, REMS administrators, sponsors, and other stakeholders to seize this opportunity to modernize REMS through piloting and iterating of the prototype. Standards-based REMS modernization can provide a foundation for future innovation and plug into the evolving health app and cloud-based environment. Working together, we can create an efficient, effective, resilient, and learning REMS ecosystem and advance public health. Thank you for your time. I'm looking forward to the discussion.
Thanks very much, Marta. I really appreciate that overview of why we're having this meeting today and why the feedback from all of you who are participating is so important, and achieving this goal of using electronic standards, well-accepted standard approaches to integrate into clinical workflows and achieve, as you said, an efficient, effective, resilient, and learning REMS ecosystem. I now want to turn to Edward Milliken and George Rapali, who are going to build on Marta's remarks with some more information on the burden associated with REMS requirements today and the steps that FDA is taking to alleviate those burdens, including through this proof of concept prototype. So Edward, George, over to you.
Thank you, Dr. McClellan. Good afternoon, everyone. My name is Ed Milliken, and I am the Senior Informatics Pharmacist within the Office of Surveillance and Epidemiology in CDER at FDA. And I'll be discussing the background for the REMS integration project and what led us to develop the REMS prototype utilizing contemporary health data standards. Next slide, please. As many of you know, a REMS may include different types of interventions, such as labs or certification to prescribe the drug. And these interventions are called elements to assure safe use, otherwise known as a TASU. And the goal of the TASU are to mitigate risks associated with the use of the drug. It's important to note that the approval of these drugs would not have occurred and may have been removed from the market without the REMS. So lack of standardization of the REMS has led to significant challenges in implementing and evaluating REMS effectiveness. Next slide, please. So sponsors of REMS drugs are responsible for developing and implementing REMS. And due to individual sponsor customization and implementation, REMS are not well harmonized and integrated into the healthcare system. And this lack of standardization of REMS with the TASU has led to very manual implementation using web portals, phone, and fax that are not well integrated into health system workflows or HIT systems. So this creates burdens for providers and pharmacists because it requires them to step outside of their workflows. And the outcome of this is additional burden on providers in healthcare systems, and this may negatively affect patient access to REMS drugs. Next slide, please. So what previous efforts have occurred to standardize and integrate REMS, and what is REMS integration? So REMS integration is the enablement of the integration of REMS processes within their respective stakeholder workflows. And some of FDA's primary efforts have focused around the REMS standardization through guidances, and in particular, the regulatory submission of the REMS document in structured product labeling, otherwise known as SPL, developed by Health Level 7 International, or HL7. Also, FDA worked with the National Council for Prescription Drug Programs, or NCPDP, which develops and maintains the CMS-adopted e-prescribing standard known as SCRIPT. And the SCRIPT e-prescribing standard currently allows the ability to create 4 transactions for communicating and completing REMS requirements. Next slide, please. So codification of REMS content and a TASU into structured product labeling is a major first step in standardizing REMS into a granular computable format. And FDA worked with HL7 to develop the REMS SPL document format. SPL captures the unique major components of a REMS via coding and structuring of the data. And there are 4 major W's that are captured, and they include these listed on the slide. The examples are the who, or responsible stakeholders, such as a prescriber or pharmacist, and the what, or the REMS requirement, like counseling a patient or lab testing. And as REMS sponsors submit and update their REMS SPL, SPL will allow for downstream users, such as drug compendia and health systems, to more readily identify REMS drugs and incorporate the REMS requirements into end-user systems like EHRs and pharmacy information management systems. Next slide, please. As a reminder, REMS SPL submission requirements began on December 28, 2022. All REMS documents submitted to FDA on or after December 28th of this year must be in SPL format, and they include new REMS, REMS with modifications, and REMS that are already in SPL format must remain in SPL format. And the REMS document is the only component of a REMS to be submitted in SPL format. Next slide, please. So health data standards play a key role in REMS integration by allowing for the automation of the exchange of standardized REMS data, and more efficient exchange of standardized REMS information could lead to better REMS assessment data. And FDA works with established SDOs to encourage the development and adoption of health data standards. So 2 examples of these I've mentioned are NCPDP and Health Level 7 International. And as mentioned earlier, NCPDP developed and maintains the US e-prescribing standard script. So in January of 2020, CMS adopted the NCPDP script version 2017-071, which allows for REMS transactions to be completed within stakeholder workflow between the prescriber, REMS administrator, and pharmacy. And these 4 transactions include the REMS initiation request and the REMS initiation response to start a REMS, and the REMS request and the REMS response to continue completion of the REMS requirements. In addition, FDA worked with Health Level 7 to develop the REMS SPL data standard for codifying the REMS document. HL7 also develops and maintains an open source hospital and EHR-focused API, or application programming interface-based data exchange standard called FHIR. And so FHIR stands for Fast Healthcare Interoperability Resources. And in the past year, FDA has been working with part of the HL7 FHIR community to develop a REMS prototype. My colleague, Dr. Nirupalli, will be discussing these innovation and modernization efforts shortly. Next slide, please. So here, the boxes in blue on this diagram show where NCPDP standards are currently used, and the gray boxes represent opportunities where the HL7 FHIR health data standard could potentially be utilized in REMS processes. The HL7 FHIR data standard can be used to bring in EHR data, such as patient demographics and lab data, into the REMS workflow that NCPDP standards may not include. And FHIR standards are being built into leading EHRs such as Cerner and Epic, and health systems are already starting to adopt FHIR, in particular the dispensing settings such as inpatient hospital and infusion centers. Leveraging FHIR along with current REMS NCPDP e-prescribing and pharmacy standards will help to ensure data interoperability through the REMS workflow. Next slide, please. So there have been challenges in the adoption of the NCPDP script REMS transaction standards to date. Current NCPDP REMS transactions have not been adopted by e-prescribing or other stakeholder systems, and gaps remain with these data standards. Even still, manual REMS processes can be prone to human error, and more work needs to be done to promote patient access to REMS drugs. So to achieve REMS integration and reduce undue burden, co-evolution between NCPDP script and HL7 FHIR is key to moving forward and better supporting REMS. The FDA is actively involved in this co-evolution progress and was invited to join the NCPDP FHIR SWAT leadership team. And I'll now turn over the presentation to my colleague, Dr. Nirupalli, to discuss the REMS integration project. Thank you. Next slide, please.
Great. Thank you very much, Ed. I'm George Nirupalli. I'm going to start with some background and definitions. HL7, as Ed has mentioned, is a health data standards development organization. HL7 FHIR is a contemporary health data exchange standard, and I'll talk about this more on the next slide. M code stands for Minimal Common Oncology Data Elements, and it's an HL7 FHIR-based cancer data standard for cancer care research and public health purposes. HL7 FHIR accelerators are collaborative stakeholder-driven initiatives that focus on solving for particular health problems with FHIR-based solutions. And finally, Codex, which stands for Common Oncology Data Element Extensions, is an HL7 FHIR accelerator focused on building a community around the FHIR-based M-code data standard to solve for problems through stakeholder-driven use cases. And we'll talk a little more about the REMS integration use case today. Next slide. A little bit more about the FHIR data standard is that it's designed to be easy to implement, free to use. It uses modern web-based technology. So for example, if you're doing a search on Google Maps, you're putting in a location and that data is sent in a certain format and you get data back. It's working through what's called an application programming interface. The FHIR standard includes a specification for an API. FHIR also splits up data into what are called resources. You can think of them as categories of information. So there's a resource on patient with demographic information, resource on medication, on observation with lab values, and there's about 145 of these resources in the current version. Next slide. So what are FHIR accelerators? They're specifically designed, and they're under HL7, the Standards Development Organization, to help communities develop implementation guides. And those are kind of the specific cookbooks. How do you use the standard? What are the elements? What are the constraints on those elements? Any extensions that are needed to solve for particular use cases and problems in the health arena? 2 FHIR accelerators that FDA is a member of currently are Codex, as well as Vulcan, which is using FHIR to support the exchange of clinical research data. One other I'll mention is Da Vinci, which is focused on advancing value-based care through the use of FHIR. Next slide. So Codex membership consists of a broad swath of organizations, from medical specialty societies, government agencies, pharmaceutical companies, and health information technology companies, as well as others. Next slide. There's also a community of practice, and this consists of a broad number of organizations as well, such as health systems throughout the country, payers, EHR and other technology companies, government agencies, research organizations, and others. And one important note is that there are monthly public calls, so this is an open community, and there are shared learnings about implementation across a number of different use cases of the M-code standard as well as FHIR. Next slide. So here you see a snapshot, and you'll see this, I think, a couple of times today, of the REMS integration proof of concept. And just a couple of points to note that this doesn't include all stakeholders in the ecosystem. This has been our primary initial focus, as well as the fact that although we're working with the Codex community focused on cancer, we're trying to develop a solution that can work for REMS drugs across therapeutic areas. And if you click through one more time, we're focused on the use of the FHIR data standard on the medical EHR side, and one more click, and the NCPDP script standard, as Ed had mentioned, on the e-prescribing pharmacy side. And together, what we hope for is to support the more free flow of data across the system, reduce the undue burden in some of the manual processes that you see, as well as generate better data for evaluation as well as timely feedback. Next slide. And finally, we're at the end of phase 0, where we've completed this open source proof of concept prototype, which is really just the end of the beginning, the start of actually working to pilot this out in real systems. And we're officially now proud to announce that we're in the planning stage of this use case. Looking forward to working with hopefully many of you to work to pilot this in the real world with synthetic data and moving to real data to get to a scalable and standards-based solution. Thank you.
Great. Thanks very much, Ed and George, for this overview of FDA's work on this REMS integration project so far, and for the preview there of some of the next steps that are coming. Based on all of this, we're now going to turn to the team from MITRE to go through a more detailed overview of how this prototype works, including a walkthrough of its core function. So for presenting this, we're going to hear from Lauren DeCristofaro, Sahil Malhotra, and Nicole Ng. So Lauren, Sahil, and Nicole, I'll turn to you now.
Great, thank you so much. Hi, my name is Nicole Ng, and I'm a Principal Software Systems Engineer at MITRE. And joining me here today, also from MITRE, are Sahil Malhotra, so a Software Systems Engineer, Lauren DeCristofaro, our Lead Software Systems Engineer. And of course, we're also joined with by FDA and the rest of the MITRE team who are listening in as well. So just to highlight that there will be some time at the end for questions. So we encourage audience members to please submit your questions via chat, and we'll take a look at those and answer as time permits. Next slide, please. In order to reduce burden and make the overall REMS program more efficient and effective, MITRE and FDA are working together to develop an open source proof of concept prototype under Codex that leverages data standards and technology to integrate REMS into the healthcare system. So we are using contemporary standards such as FHIR and working closely with NCPDP to coordinate efforts. And really the goal of the prototype is to focus on modeling data transactions and workflows to demonstrate the art of the possible. So we're not aiming to develop an interface for users, but are really focused on showing how REMS data can be exchanged and used. We're really using the prototype as a means to engage the broader REMS community to help drive conversations around opportunities to enhance REMS. And so with that, I'll turn it over now to Duke. Could we please play the recorded video of Sahil giving a demo of the prototype? Thank you.
Hi, everybody. My name is Sahil Malhotra. I'm a software developer here at the MITRE Corporation, and I'm here to talk to you about the FDA's Risk Evaluation and Mitigation Strategies, or REMS, open source proof of concept prototype. We're currently on release version 0.7, and I'm here to talk to you guys about what we've been able to do so far. So with that said, let's get right into it. Over here, I have a timeline of kind of our various different releases that we've had so far. So back in January of 2022, we released REMS version 0.1. And for this release, we kind of focused on the prescriber workflow, mainly leveraging open sourced projects from the Vinci prior authorization solution and using those servers as a starting point rather than starting from scratch. Our next release was then on March 14th of 2022. And for this release, we added pharmacist integration into the workflow and focused on the interaction between the prescriber and pharmacist as well. Release version 0.3 was done on April 25th. And for this release, we focused on the REMS administrator workflow and the communications going on between the prescriber, pharmacist, and REMS administrator as well. REMS version 0.4 was done on June 6th. In this release, we focused on improving the existing stakeholder workflows, added initial education support, and also added a REMS administrator database to help facilitate the conversation between those three major stakeholders that I mentioned before. REMS version 0.5 was done on July 18th. In this release, we added verification of REMS ATASU, extended our education support, and also began initial patient portal support as well. REMS version 0.6 was then on August 29th. In this release, we extended our patient support fully and fully integrated a patient portal. We added improvements to the verification of individual REMS ATASU, and we also extended the support of ATASU data elements for both TERF REMS and iPledge as well. And then that brings us to REMS version 0.7, which is the end of the complete proof of concept phase of the project, or phase 0. This was on September 29th. And for this release, we focused on creating a UI for prescriber requirement submission. We also added iPledge ATASU support. And then we kind of cleaned up any miscellaneous bugs that we had in UI tweaks that we wanted to make, as well as documenting everything that needed to be documented in terms of like our READMEs and install instructions and making sure everything was good there. So with that release schedule out of the way, let's get into the workflow as a whole. So over here on this slide, you can see that we have 4 major stakeholders involved. We have the prescriber over here on the left. We have the patient at the bottom left over here. We have the pharmacist at the bottom right over here. And then we have the REMS administrator at the top right over here. So we're going to be looking at how all 4 of these stakeholders kind of communicate and go through the workflow of a REMS request. So the first part is the patient is going to go to see the prescriber at some kind of hospital setting in a patient encounter. And then once the prescriber kind of verifies what's wrong and what needs to be prescribed, the prescriber in step 2 is then going to reach out to the REMS administrator, asking the question, does this drug have REMS? And so this is going to be a many-to-many relationship between the various prescribers and EHRs that are out there and the various REMS administrators as well. So one thing to mention about this communication is that the question of does a drug actually have REMS is typically going to be stored in the EHR already. So this communication isn't going to necessarily have to happen in production. But in terms of how our prototype is set up, this is a limitation that we have, and we currently do have the prescriber reaching out to the REMS admin to get kind of the REMS information that it needs. So step 3 is going to be for the prescriber to fill out any of the REMS requirements that were received by the REMS administrator. And then they're going to go ahead and submit that prescription information and REMS compliance bundle to both the REMS administrator and then the pharmacist respectively. In step 4, we're going to have the pharmacist reach out to the REMS administrator and verify that all of the individual REMS requirements have been met and that it is going to be safe for the pharmacist to dispense the REMS medication. And then in step 5, we have the prescriber and pharmacist communicating back with a status update so that the prescriber can see if the medication has been picked up by the patient and if everything is going smoothly as according to plan. So that's a brief overview of kind of the communications involved between the 4 major stakeholders here. I'm going to go over 3 different scenarios that we have set up in our prototype because we have 3 different REMS medications hosted inside of it. So scenario 1 is going to be Turalio. So this is going to be asynchronous completion of the patient enrollment form. So what's going to happen is, for example, the patient's going to go see the prescriber in a hospital setting. The prescriber is going to send the patient home, and then they're going to start working asynchronously on this patient enrollment form. The prescriber can assign it to a nurse. They can start it off. And then the patient can go in and verify all the information and sign it. And then finally, the prescriber can go ahead and sign and submit the form as well. And then upon submitting that, they will see a status of any individual REMS requirements that still need to be met, and the prescriber can go ahead and follow up and complete any of those requirements that need to be met. And then finally, once everything has been submitted, including the patient enrollment form, prescriber enrollment form, and prescriber knowledge assessment form, the pharmacist is going to be able to verify that all those requirements have been met and then dispense the medication safely. The second scenario that I have is going to be iPledge, and this is going to be a synchronous completion of the patient enrollment form. So the patient's going to come in, see the doctor in a hospital setting, and then both the prescriber and patient are going to go fill out the form together by handing around an iPad or some other medium of choice to fill out the electronic form. So we're going to start with the prescriber actually filling out their prescriber enrollment forms in this case first, and then filling out the patient enrollment form with the patient. And then what you'll see in this example is that because all the requirements have been submitted before the patient enrollment form, it's going to be almost instantaneous approval of the REMS request. And then similarly, once all those requirements have been met, the pharmacist can go ahead and dispense that medication. Scenario 3 is going to be for TERF. So we do have support for TERF in our prototype. We're not going to actually go through the demo of TERF simply for time. But you can follow either in a synchronous or asynchronous completion of the forms, as you'll see with Turalio and iPledge, and you can submit them in kind of any order, and you'll have those same requirements that are being shown as well. So with that said, let's get right into the demo. So over here, what I have is what we call our CRD request generator. This is basically like the UI of the EHR, and it's going to be the starting point of our whole workflow. So we're going to start off with scenario 1, which is going to be Turalio, and we're going to do this asynchronously with a nurse and patient prescriber kind of handoff happening. So if we go over here to patient John Snow, we can hit request, and we can select Turalio. Clicking on his name is then going to load all the patient information and medication information into this UI over here. And then when you hit submit to CRD, CRD is acting as our REMS administrator server. This is going to come back and return 2 cards saying that the drug does have REMS and that documentation is required. You can see that we have the patient forms over here and the prescriber forms down here. And for each one, we have some PDFs that link to kind of the different requirements that are there. So we have a medication guide for the patient, a patient guide, and then we have the enrollment form. And similarly for the prescriber, we have the prescriber information, the program overview, and their training, as well as their respective forms as well. So what I'm going to be doing as the prescriber is sending the patient home, saying we're going to send you the patient enrollment form, and I'm going to be assigning this to my nurse and say, start working on this patient enrollment form for me. And then putting myself in the role of that nurse, I'm going to click on this patient enrollment form button, and we're going to open up what we call DTR. So first things first is going to be to log in with some credentials. So over here, this is just going to be Alice as the username and the Alice as the password. With signing in, this is going to load DTR, which is a Smart on Fire app that kind of launches with the context of the EHR. And basically, this is going to be like a really fancy Google form that just kind of asks some questions and allows the user to input some answers. In the top right over here, we have this only show unfilled fields option. So if we uncheck this, you can see that we get a lot more questions shown for us with some of the answers actually already pre-populated for us. And so that's the really cool thing about DTR is that this is launching with the context of the EHR. It's reaching out and with the correct scopes and getting as much information as it can and pre-populating the form for us. So this kind of helps to reduce burden because whoever is filling this out doesn't have to go by one and verify and fill out each information. It's already kind of filled out for us there. So you can see we have the patient information filled out. We have some prescriber information filled out. And we even have baseline lab tests filled out for the patient, each of which was taken on different days. So again, this kind of helps to reduce burden because the nurse or prescriber, whoever's filling this out, doesn't have to go and check each test one by one. They can just verify that it all looks good and it's all accurate and up to date. So what we're going to do, again, as the nurse, is going to check this off and fill in any information that needs to be filled out still. So for telephone, we can create a telephone number for a patient. We can also do so with an email. We can set his height as 5'7". For race, we'll say white. And then we can continue on and also set a hospital name for the prescriber and kind of skip through everything else because it's already been pre-populated for us. All the medication information was already filled out for us. So what we're going to do now as the nurse is go ahead and hit the Save to EHR button. What this is going to do is take the in-progress form that we just saw and actually save it to the EHR. And this will allow for the patient or prescriber to continue where we left off. So through some sort of mechanism, we'll let the patient know that he has a form to sign and fill out. We have a patient portal over here. So you can see we have John Snow as our username and John as our password. If we log in, clicking this, you'll see that we have an in-progress questionnaire. So we see that this was last updated on the 27th of September. And if we click on this, this is going to load up that same in-progress patient enrollment form that we had already started working on. If we hit this only show unfilled fields option, you can see that we see the phone number, the email, the height, as well as the hospital name that we all filled out as the nurse. So now putting myself in the roles of the patient, I'm going to go ahead, verify all of my information is correct. And then down here, I'm going to sign my name as patient John Snow. And I'm going to do exactly what the nurse did as well. I'm going to go ahead and hit the Save to EHR button. And this will allow the prescriber then to go in, sign, and double check all the information. So if we go back over here and refresh our EHR UI, we can go back to Patient Select, click In Progress Forms, and you can see that we have two over here. What we want is the bottom one, which will have that patient signature as well. And if we click on this, we can hit Relaunch DTR and finally fill out the rest of the form and sign our name correspondingly. So before I sign as the prescriber, one thing that I want to make a note of is that the onus of verifying that all of this information being correct is still on the prescriber, even though a lot of it has been pre-populated for us. So we actually have this attestation button in the top right as well. And so the prescriber can go through one by one, verify that all of this information looks good. And then once it has done so and it looks good, they can go through, go to the bottom and just sign their name. So prescriber Jane Doe. And then now this patient enrollment form is completely filled out and is ready to be submitted to the REMS administrator. So what we're going to do is submit this to the REMS administrator with the Submit REMS Bundle button. So doing so is going to open up a status field, and you can see that we have a REMS administrator status on the left and a pharmacy status on the right. So if we go ahead and hit View ETASU, you can see that we have our various different requirements. We have the patient enrollment form, which we just submitted, the prescriber enrollment form and prescriber knowledge assessment form, which both need to be submitted still. And then we have the pharmacist enrollment form as well, which has also been submitted. So in our prototype, we're kind of mocking out all of the pharmacist, ETASU, and individual requirements for the moment in our database, but we have support to show how the prescriber would go through this workflow. So the next step to do is really, as the prescriber, go ahead and submit those respective prescriber enrollment and prescriber knowledge assessment forms. So let's go ahead and do that. Refreshing the EHR UI, we can go back here, select Turalio for patient John Snow, and if we hit submit to CRD again, we'll get back to the same two cards. It really doesn't matter which one of these we start with, but let's start with the prescriber enrollment form. So over here, we'll load up DTR again with a different questionnaire. You can see we have a lot of the fields already pre-populated for us for prescriber information, contact information, and so on. And then we just need to sign here as the prescriber. Now, one thing I want to talk about before I actually go ahead and sign is that we have this question here for prescriber certification. And this is actually pre-populated for us coming from the EHR with certification information for the prescriber Jane Doe. So what this is going to show is external integration options for continuing education, where what we could do is pull information from the EHR for certification. And instead of having to submit that knowledge assessment requirement, that could potentially be submitted through the patient or prescriber enrollment form just by pulling out that certification if that was handled externally through some other continuing education platform. We don't have full support for this feature. Currently, we're just pulling from the EHR. So to continue on with the workflow, you will need to actually also submit the knowledge assessment form just to complete that requirement. But you can see how that would potentially work out in practice. So what we're going to do is say that this form is completely filled out. And we're just going to go ahead and sign as prescriber Jane Doe. And we're going to hit Submit REMS Bundle. This will load up a UI saying that our prescriber document has been submitted respectively. And if we go back to our original screen, we can actually hit refresh over here, and you can see the prescriber enrollment form has been submitted to the REMS administrator, and our status has updated respectively. Similarly, if we go ahead and do the same thing for the prescriber knowledge assessment, which again, typically if we had certification already, we wouldn't have to do so, but we don't have support for that in our prototype yet. We can just go ahead and quickly answer the first answer for all of these knowledge assessment questions. You can also see that we have the prescriber information pre-populated for us at the top as well. And then we can go ahead and submit this REMS bundle as well. And you can see we get another documentation successfully submitted. And if we go back to our UI and refresh one more time, you'll see that our prescriber knowledge assessment has been completed. All of our various ETASU or elements to assure safe use, or basically any REMS requirements, have already been submitted. And our status has correspondingly changed from a pending state to an approved state, which means it is now safe for the pharmacist to also go ahead and dispense this medication. So with that said, let's switch over to our pharmacist view. So going over here, we have our PIMS system. which is Pharmacy Information Management System. What we can do is log in the top right over here. I just have some credentials here, which is susiefarmichael@example.com, and then Susie as the password. So logging in, we can then go to our doctor order screen over here. And in new orders over here, you can see that we have that prescription that we just submitted for patient John Stark Snow. So if we go over here to the right, you can see we have two buttons. We have order verify and view order. If we click on view order, you'll see the same REMS requirements in ATASU that we saw earlier for the prescriber UI. Similarly to before, the prescriber enrollment form and prescriber knowledge assessment form have not yet been submitted according to what the pharmacist can see. So to check if those have been, what we can do is just hit order verify, which is the same order verify button that will be over there. This will reach out to the REMS administrator, and you can see we'll update the status to say that it has been verified by the REMS administrator with all of the requirements being met. If we close out of this, we can go over to our verified order screen and see that we have this order as verified. And so when the patient comes in and ready to pick up the medication, all we have to do to dispense it is hit this picked up button like so. And you will see that this moves over from the verified order screen to the picked up order screen like so. Lastly, what we can do is go back to our original UI and hit refresh on the pharmacy status. And you'll see that our status has changed from pended to picked up. And that concludes our example for Turalio. So now what I'm going to do is go ahead and close out of all of these open questionnaires that I have. And what we're going to do is go ahead and refresh over here in our EHR UI. And then we're going to go on to our next example, which is going to be iPledge. So if we click on patient select, we can go back to John Snow, click on isotretinoin, which is iPledge, and populate the UI as so, and hit submit to CRD. This is also going to show us two cards, again, for the patient and the prescriber respectively. And we can continue on with our second scenario. So in this scenario, what we're going to do is do everything synchronously. So the patient's going to come, see the prescriber, and we're going to fill out the form in the hospital setting together, possibly by just handing around the iPad or whatever medium that we're using to fill out this form. Before we get to the patient enrollment form, I'm really quickly just going to start with the prescriber enrollment. So over here, this will load up DTR once more with the prescriber enrollment form. You can see that we have a lot of our fields pre-populated again. There's that certification information that I was talking about. And so the last thing left to do is simply sign. So we can go over here and say, I attest to the above statements and submit our prescriber enrollment form to the REMS administrator. Now, when we go ahead and with the patient, we can go through and fill out the patient enrollment form. And so this is going to load DTR again. You can see we have our only show unfilled fields, and we have a lot of information pre-populated for us. The really cool thing about iPledge's patient enrollment form is that there's actually two versions of the form. There's a version for patients who can get pregnant and a version for patients who can't get pregnant. So what we actually did for iPledge is combine both of those PDF questionnaires into one form that uses dynamic questions to load in future questions. So this first one over here, determine patient category, if we check this off, you'll see that we get additional pregnancy related questions. And if we uncheck this, you'll see that we get non-pregnancy related questions load in as well. So that's the really cool thing about iPledge. What we can do is then go ahead and fill out the rest of the information for the patient. For now, I'm just going to skip through this in the interest of time and get straight to the attestation portion. So as the patient, I just need to go ahead and sign as patient John Snow. So JS for my initials and then John Snow as my signature. And then lastly, we're going to hand it off to the prescriber. They're going to check off their respective forms, fields, and then sign as prescriber Jane Doe. And then what we can do is go ahead and submit this to the REMS administrator. And if I scroll up over here, you'll see we see the same two statuses that we saw with Turalio. The only difference is we automatically have an approved status now. If we hit view ATASU, we have three different ones required: the patient enrollment, prescriber enrollment, and pharmacist enrollment, and all of which have been submitted. So we get that kind of instantaneous REMS request approval when all of the requirements have been met. Again, we kind of mocking out the pharmacist requirements for the time being, but we went through and submitted the we went through and submitted the prescriber enrollment form before doing the patient enrollment, and that's what lets us get that almost instantaneous approval. Now, what we can do is go back to our pharmacist information view. If we go to new orders, you'll see that nothing's actually been here because the prescription that we sent is already verified by the REMS administrator. So it's actually going to pop up in verified orders. And you can see that we have isotretinoin. And when it comes time to dispensing this to the patient, all we have to do is hit picked up, like so. We'll move over to the picked up orders tab. and we can see that we have our isotretinoin and Teralio medications both picked up. And similarly for the prescriber, they can just go ahead and refresh and see that status update when the patient has been dispensed the medication. So that brings us to a close for our isotretinoin example and scenario. Just a reminder that we do have support for TERF as well as a third scenario that you could walk through. But in the interest of this demo, we're going to stop right here in the interest of time. So thank you all for listening, and I hope you all have a great rest of your day.
Great, thank you. If we could go back to the slides, please. All right, so you just saw a video showing what is currently in the prototype, but what is next? As George mentioned, we are moving into the next phase 1, which is really focused on piloting a REMS integration approach at a health site using synthetic data. And we will continue to work with the Codex stakeholder community to define the scope of a pilot definition of the prototype, test the approach at a health site, and start defining a FHIR standard specification for REMS. Next slide, please. Community engagement is critical to success. This is an opportunity to drive direction for the REMS integration approach. It's an opportunity to help develop a use case to identify specific REMS elements of interest in initial piloting, implement it through FHIR and NCPDP standards. And so we welcome everyone here and also the larger community and the public to participate. And below on the slide here are ways for how you can do so. So I'll point out that one of the best ways to participate is to join some of the REMS public calls and also reach out to, there's an email at the bottom here to Kelly, who is the REMS integration use case coordinator. So please, we would love to hear from you. And with that, I will now turn it over to Lauren and the rest of the team to answer some of the questions that we've been getting in chat. Lauren.
Sure, sounds good. Thanks, Nicole. So I guess the first question in chat is from Jamie Wilkins. So I'll go ahead and answer that. So this is where did the data sources receive their data? Is it supported by REMS at FDA or other means? And so yeah, where we're getting kind of all of that information that comes up in those cards is directly from FDA sites and you know, from the maintenance of the information about that program. So it is sourced from FDA, and that is a good question. The next one that we're going to answer is from Rima Mehta, who asked, who maintains the data/forms in the app? And so the forms are, so in our prototype, kind of, we've created these forms based on the existing forms that you can find kind of as open information on each of the REMS programs. But we kind of have that hosted in the entity that's the REMS administrator side of things. So the REMS administrator is the one who administrates those forms. So kind of they're the ones that would be the control on what those forms look like and what kind of information is needed to meet those requirements for the program. Let me see, the next one is from Jane Leong, and I think Sahil, you were going to answer that one.
Yeah, certainly. So the question is, I've managed several REMS programs where the patient is required to train on/review REMS patient materials prior to enrolling. How does this system support these differences in REMS ATASU elements? So the idea here is that any kind of training and materials that you would go over with the patient kind of in a hospital setting would still happen. And then what we're trying to automate is more the submission of forms and the communications between the prescriber and the REMS administrator. So we didn't show that in the demo in the interest of time, but in those cards that we sent back, there are actually links to PDFs of all like the guide, patient guides and prescriber training and stuff like that. So yeah. Back to you, Lauren.
Yeah, I guess the next one, I think, so is from Anonymous. So is this mockup meant to be used or just meant to be an API that gets integrated into another EHR system? And so the purpose of the prototype is really to help kind of show potential ways forward and explore potential ways forward with the community. So we're really looking for that feedback. We're looking for thoughts on kind of where this can go in the future. And so we're kind of demonstrating the potential for how these different systems can communicate. And so our hope is that, you know, as more folks get involved, they're excited about kind of taking on a standardized approach for doing this communication so that the right information can get to the right places in the system. So I hope that's helpful there. The next question we have is from Jamie Wilkins. So will the prescriber be required to do some type of re-enrollment, even with knowledge assessment pre-population for each patient enrollment / verification? And so the answer there is no, we don't expect that. Right now, we kind of have a more limited set of the use case that we're looking at, which is looking at that kind of new enrollment. You know, we have a new patient, you know, or we have a prescriber that's new to actually prescribing this medication. So we're showing kind of that first phase. We would expect that, you know, that you wouldn't have to re-enroll every single time as a prescriber. If, you know, you've done this before, that information would already exist in the system. But we just don't have that kind of shown in the system right now with the current prototype. Yeah, let me just check. So I think we have a couple of other questions coming in. So let's see what else we can answer. So the next one is anonymous. It says, will e-signature versus typed name be built as a capability in this UI? So we definitely see that being a potential that could be integrated in. Kind of doing a signature electronically, I think would be really helpful. It's a little bit of a solved game, if you will, being able to do kind of electronic signatures. So we don't directly demonstrate it in our prototype, but we do imagine that would be really valuable to be able to do that to help kind of directly integrate into a digital format with form signatures. What else do we have? So we have a couple minutes left. So the next question that I see is the EHR UI a plugin for the EHR, meaning once invoked, the prescriber/nurse will need to complete these forms outside of the EHR. Once they are done filling out proper forms, are they redirected back to their EHR? So actually, it is not kind of something that directs you outside of the EHR. So because it kind of uses these FHIR technologies, it is a way of sort of directly being able to complete this information in workflow within the EHR. So it's a way of kind of bringing it up within that context of the EHR. You know, it might even have or is likely to even have EHR theming and kind of look like it matches the EHR, but you know, you can pull the functionality from outside of the EHR in order to do it. So the nurse or prescriber would be able to complete the forms within the EHR, would actually could indeed save the forms and then come back to them later within the EHR and complete them kind of within that workflow within context. Yeah. The next question that I am seeing, so does the REMS administrator have access to all the transactional data in the system, for example, for reporting and REMS assessments? So, you know, so we envision the REMS administrator is receiving kind of all of that, the same information they need to verify that all of the requirements have been met for the program. So, you know, it's you're receiving those forms that are required and being able to send back information about what requirements have been met. So I hope that answers that question. I guess I want to quick check in with the team. Any other questions that you folks want to make sure we answer before we hit our time?
That was fantastic. Thank you, Lauren. I'll just note that we do see the rest of the questions in the chat, and so we will do our best to respond to them in the chat. So thank you so much. And I think we'll turn it back to Mark. Thank you.
Yeah, Nicole, Lauren, Sahil, thanks for a great discussion. A lot presented in there and a lot of questions you got through. If I could just ask one clarifying question, I think go to a couple more that are left in the chat. So MITRE's developed an open source system here. And as you're envisioning it, this is something that, say, electronic health record vendors could take further steps to more seamlessly integrate into electronic systems, isn't it?
Yeah, so this is an open prototype. We're really building off of technologies that a lot of EHRs are working with, that some of which are actually required to be implemented in EHRs for through CMS regulations. And so the intention is to be able to let this as seamlessly integrate with an EHR as possible, and kind of, yes, provide this as an open source way of, how can we increase that data flow, make sure that the information is getting to all of the right places in an automated fashion that doesn't cause burden for stakeholders.
Great. Well, thank you all again for the presentation, the work on this. And now we're going to kick right into our first panel on provider perspectives on this prototype and on this general goal of making progress of using electronic standards and integration into electronic record systems to have a more seamless approach to addressing REMS in clinical contexts. And for this panel, very pleased to be joined by Lane Abernathy, who's a patient advocate for amyloidosis patients, who was prescribed a REMS drug as part of her own amyloidosis treatment. Robert Cotes, a member of the clinical expert team for the SMI Advisor, a clinical support system for serious mental illness funded by SAMHSA and administered by the American Psychiatric Association. And third, Ilona Frieden, who's chair of the American Academy of Dermatology Association's iPledge work group. We're going to start with some opening comments, about 5 minutes or so from each of these three panelists, and we're going to have some discussion. Once again, you all who have joined us today have been very active in participating so far. Please keep those questions and comments coming. We'll try to get to a number of them in this session as well. So let's begin by turning to Lane. And Lane, if you're with us, you may want to go off mute. See, not
there I am.
There you go.
There I am. Hi, I'm Elaine Abernathy. And yes, I'm an amyloidosis patient. I was diagnosed about 11 years ago. And at that time, there was really no treatment for this disease. It's HATTR version. I inherited it from my father's side of the family. My father sadly died at 49 in 1968, when there really was no information available. But at the time of my diagnosis, about the only thing they could do, the medical folks could do, was treat symptoms. I had a heart and liver transplant a little more than 10 years ago, and I continue to be followed for that. I've done really well. In 2018, a medication did come on the market, was commercially available, FDA approved before that. And I was able to take that medication. It came with a REMS requirement, which I really appreciated because of my amyloidosis and my heart and liver transplant, and the known side effects that had been observed with this particular medication. I was required to have weekly blood and urine labs. Liver labs were done as part of this. Also been some clinical trials for other medications that were showing significant liver issues and were not really appropriate. Those plantation. So this really helped me be sure that the medication was not doing something negative to my health. In fact, after being on the medication for about 3.5 years, these side effects did become too great. I had significant platelet count drop, and I would not have known this had it not been for the weekly monitoring. So I appreciated tremendously the fact that somebody was watching what was happening to me. And the REMS program itself was not onerous to me. It really wasn't. During the pandemic, a mobile examiner came out to do blood draws and take urine specimens, but that was fine. I also then, when my numbers look good, could give myself self-administered injections of the medication, but eventually I did have to come off the medication because of the side effects. And I appreciate your interest in all of this. The biggest thing that most of the communication was behind the scenes. And I was not really in the middle of any of that, other than to say that when I had a mobile examiner coming out, there was no way I had access to the lab results. And I know that because amyloidosis is a really relatively rare disease, the provider who was treating me, the prescriber, had his physician's assistant checking my labs. So she had to check them every week, then let me know, let the physician know to make a determination, let me know. But I never really got the lab results unless I specifically asked for them. And then I had to let my transplant teams, both the liver and the cardiac, know. So there was a requirement for a sort of connection in the middle there that was missing. So this seems like it could be incredibly helpful in that regard. Thank you.
Great. Thanks very much, Lane. Really appreciate your perspective and that point about potential for increased transparency through clinical data system integration. Now I want to turn to two perspectives from the prescriber side of this. So we want to be seamless from a patient standpoint, but also not burdensome from prescribers knowing what's required and collecting the appropriate information. For that, I'd like to first turn to Robert.
Hi, everyone. I'm so delighted to be here. My name is Rob Cotes. I'm an associate professor in the Department of Psychiatry and Behavioral Sciences at Emory University School of Medicine. I currently serve as director of the Clinical and Research Program for Psychosis at Grady Health System, which is a public hospital in Atlanta, Georgia. So responding to a need in our health system and in our community, I developed a clinic for individuals with treatment-resistant schizophrenia, focusing on the use of clozapine. And ultimately built a multidisciplinary team to work with these individuals. We currently work with about 120 folks on clozapine right now. I'm a researcher, educator, and also frontline clinician. As mentioned in the introduction, I serve as physician expert for SMI Advisor, which is a SAMHSA initiative administered by the American Psychiatric Association, for which I answer psychopharmacology consults from psychiatrists and other prescribers across the country, and the majority of them are on clozapine. As a disclosure, I have received research funding within the past 3 years from Otsuka, Roche, and Alkermes. I'm a paid consultant to Saladex Biomedical and the American Psychiatric Association, and an unpaid consultant to HLS Therapeutics, and also a speaker for Clinical Care Options. So I guess some opening remarks, regarding clozapine. Clozapine is an atypical antipsychotic medication that is highly underutilized in the United States. It's estimated that about 23% of individuals with schizophrenia have what's called treatment-resistant schizophrenia, which means that they've failed 2 antipsychotics prior to that. But unfortunately, only about 4% of individuals with schizophrenia are actually prescribed clozapine. Clozapine is the only medication approved by the FDA for treatment-resistant schizophrenia, and the only one really in the literature that's been demonstrated to be effective at all for this condition. Now, clozapine is highly underutilized in the US compared to other nations across the world, and in the United States as well. Clozapine is even further underutilized among racially minoritized individuals. So one of the main barriers for clozapine's use, the research finds again and again, is the administrative burden and the REMS system. Just so we're all on the same page, the absolute neutrophil count needs to be updated in the REMS system every time the medication is dispensed. And the frequency for clozapine is weekly for the first 0 to 6 months, every other week for 6 to 12 months, and then monthly after one has been on the medicine for 12 months. The administrative burden is quite significant. And for every minute I'm spending with a patient in direct face-to-face content, I'm spending 1 minute in the clozapine REMS system, and also faxing labs to the pharmacy. After the changes to the clozapine REMS system in November 2021, some prescribers stopped prescribing clozapine entirely, and also some pharmacies stopped dispensing it. So I think that with the REMS system, there is an addition, there's certainly administrative burden, and also there's a perception of administrative burden that drives down use. So I think that incorporating REMS within the clinical workflow is a very, very exciting prospect to help save time. And for the people that do prescribe clozapine, unfortunately, which is not a lot of prescribers, it could really help to, sort of increase the number of people that I can ultimately serve.
Great. Thanks very much for your comments, Rob. And I want to come back to how this program could potentially alleviate that, and maybe why there haven't been steps already to incorporate these REMS requirements into clinical processes. But first, let me turn to Ilona for some comments related to your experience and how this approach might help, or what some further considerations are with respect to iPledge.
Thank you. My name is Ilona Frieden. I'm a professor and a pediatric dermatologist at UC San Francisco, and I am chair of the AAD iPledge work group. I don't have any other relevant disclosures. Thank you again for allowing me to participate in this session. Isotretinoin is an extremely effective and important medication in treatment of severe and recalcitrant acne, and it's used in several other medical conditions as well. We estimate that there are about 1 million prescriptions per year. So this is on a very different scale than some of the other things that have been talked about, with about 200,000 people in the iPledge REMS system at any one time. The REMS program was established in 2010. I believe it's one of the oldest programs of that type, and its main object is to decrease fetal exposure to isotretinoin, which is a known and very potent teratogen. The requirements for iPledge for those who can become pregnant are very stringent, and they include monthly attestation by both patient and provider, monthly pregnancy tests and visits, a 30-day waiting period to start a medication, a 19-day waiting period if you miss the window of a pregnancy test, and other documentation requirements. And so the example that was used in the video was really not accurate, certainly for those who can become pregnant. It's more similar to the case of Turalio, which was shown. It's also worth noting that the administrative burden for those who cannot become pregnant and therefore not have issues with birth defects are unfortunately nearly equal. This slide, as a dermatologist, the picture is worth 1,000 words to me, shows the logistical burdens of the REMS program very vividly, and the thicker lines correlate with the time and greatest frequency of communications. Next slide, please. This next slide shows the number of communications for only 144 acne patients on isotretinoin and also patients who were not on isotretinoin. And those on isotretinoin had nearly 6 times as many communications as those not on isotretinoin. So you can see the incredible logistical burden to patients overall, pharmacies, insurance, and that's a huge burden. Changing insurances and then having to get prior authorization can derail this entire process. These administrative burdens have led to proven healthcare disparities. The burdens of the REMS program lead clinicians to not necessarily use the medication, use less optimal medication, use more antibiotics, despite the need for antibiotic stewardship. And this effect is unequal, and it has more effect on impact on those who have lower socioeconomic status, health literacy, and those in rural locations. So we absolutely support the concept of streamlining the program, and we welcome these technologies. But there are certain anticipated pitfalls. We welcome the ability to work with you to try and overcome these. If I can have the next slide, I will show you that there are really major inconsistencies, and this is a snapshot of the REMS programs who do have a focus on teratogenicity, fetal exposure. And they're very, very variable in their approaches. And this is going to make it harder for implementation to happen because they're so all over the map, and this is not for evidence-based reasons. This is for reasons that we don't frankly completely understand. It's also really critical that the platform needs to handle asynchronous qualification to receive drugs, since pregnancy testing actually has to occur. You can't just enroll someone when they sign their consent form. They have to have a pregnancy test in hand to really initiate that program. And they may not be, and likely are not going to be, in your office when that happens. So these proposals need to be able to handle this. They should be neutral or ideally help with alleviating health disparities rather than worsen them. And this may require workarounds, such as the ability to consent patients who don't have broadband use or are not in the office if we're doing a telemedicine platform. And some of the information, as we noticed, such as pregnancy tests, will not be available at the time of many visits. And so this, again, needs to be asynchronous. And if I can just finish by emphasizing, transparency and accountability are key. So this should help. It should help us to provide data so we better understand what the barriers are. And right now, that's really a big black box to us. I want to therefore compliment the organizers on their initiative in actively involving the stakeholders. This is something that we believe needs to be done by the FDA going forward. Open communication among the stakeholders, including the sponsors, that is the manufacturers of the medication, has not really been traditionally, has not happened. And we would like this to continue. We ask the FDA to continue with that initiative, along with continuing to work on the kinds of programs that you've outlined today. So thank you very much for allowing me to present.
Great. I want to thank you all for your opening comments, and I appreciate the thought that went into the assessment so far and the further issues ahead. And we have some follow-up questions related to that that I'd like to start with. And again, we encourage those of you who are joining us to submit questions. And if any of our panelists want to answer those directly on the Q&A tab, please go ahead and do that too. But let me start with the prescriber perspective. And this, I think there are versions of this both for you, Rob, and for Ilona. So it was great to hear at the start from Lane about how relatively seamless her experience was, but both of you described for people who especially haven't made it into routine therapy with a REMS drug, some obstacles in getting there and some ways in which this prototype program might help advance the clinical workflow integration and reduce burden. But I would like to follow up on that, since it doesn't seem like that pathway, at least in your experiences, is completely straightforward. And maybe, Rob, to start with you, with that big gap between where it seems like from the evidence clozapine prescribing should be and where it actually is, have there been some significant efforts so far to try to integrate the neutrophil testing and results reporting into the electronic record system, say, that you're using or that others are using? And if not, why have those not come along already?
Yeah, I think that's a great question. And to my knowledge, there really hasn't been a lot of efforts to do that. I think one of the challenges with clozapine is the heterogeneity and the system of which how people kind of get the labs, get the blood work, and then ultimately get the medication. So, one of the challenges is the labs are often in a lot of different places. So I'm often looking at 4 different systems in order to look at the lab. I'm looking at my own fax machine, my own EMR, and then that of Quest or LabCorp or other sort of laboratory companies. So the information really is spread out, which is why I think this initiative is so I think why this is so great, because it can really have the opportunity to streamline things considerably. And really, right now, the variation is the source of considerable problems. And with clozapine, there's really no margin for error. If somebody misses a day or 2 of the medicine, they can have all sorts of significant problems. They can, have a relapse in symptoms. They can go back to the hospital, or sometimes worse. And just the idea of not being able to get the medicine is a source of anxiety for patients, I think, every day, even if they've been on the medicine for years. So to my knowledge, really not much has been done in terms of integrating the absolute neutrophil count monitoring into the REMS system so far.
Yeah, and for somebody like you who's trying to, as you mentioned at the outset, build a program that really is patient-centered and involves a care team around these unfortunate patients with treatment-resistant schizophrenia, that seems like a significant barrier, but one that may require, I guess, more of an integrated push. And we heard earlier that there are some CMS requirements about adoption of HL7 FHIR standards that I think are meant to align with supporting that kind of data integration. There's been a lot of work on advancing data transparency and interoperability. Are there some other policies maybe outside of what FDA is doing in this prototype context that could help advance that kind of data integration goal that you're talking about?
Well, we've often wondered. I think that one of the things about clozapine is that the absolute neutrophil count monitoring is indefinite for after somebody's been on clozapine for a year, and we would really like to convene a scientific review to see if it is actually necessary to continue the indefinite absolute neutrophil count monitoring. And I think that a system like this can actually help us to get the data in a way that's more transparent, so we can figure this question out or not. Because right now, in the United States, the vast majority of people on clozapine are on clozapine on a monthly basis, and they've been on it for a long period of time. So potentially having the data to remove the overall number of people in the system, I think might help things a great deal.
And have that data, and that not only the testing data, the neutrophil testing data, but how the patients are doing subsequently, that kind of learning health system goal that we heard about earlier. It seems like it could be a way of developing the evidence needed to update REMS systems as well. Alon, let me turn to you. You raised some different, conceptually similar, but different context issues around access and equitable access that were complicated by the REMS requirements. And maybe just a similar version of the same question. Are there electronic clinically integrated approaches to iPledge out there that you've seen that do work, that this could build on? And if not, why haven't we seen more of this already?
Well, there was a major revamp about a year ago, a little less than a year ago, when the platform, the iPledge platform, migrated to a different vendor, and which caused a complete breakdown in the system. And I believe the same thing happened for the drug Dr. Coates is mentioning. And so that was just a complete disaster. And we obviously were patients for months, couldn't get medication. 8 hours on a call center waiting to speak to a live human, and a complete kind of an epic failure. But if I can, so there are many themes. One of them, I completely agree with Dr. Coates. So I think it's really important to understand, as the technology moves forward, that the system, the way REMS programs are set up by the FDA, the sponsors, which in the case of isotretinoin is 7 different manufacturers of the medication, they are required to administer and update the program. And so things like, which we have tried very hard to say, for example, why would the attestation requirements for people who cannot become pregnant be equal, other than the monthly pregnancy test? Why do you even need monthly monitoring at all? In the beginning, when we used iPledge, we did monthly monitoring because we didn't know better, but it's very clear now that liver function tests, lipid changes, you can do a couple of tests and then you don't do anything unless someone becomes symptomatic. So those things have gone away in terms of quality improvement of actually making this more cost effective. The majority of people in the iPledge program cannot become pregnant or in that category, partly because that's the only other alternative other than antibiotics. They can't use oral contraceptives and spironolactone, for example, to treat their acne. So they're the majority. And so to move people out and make the program more streamlined seems like a very laudatory goal. And yet we've really made no progress thus far in getting either the sponsors or with advisement from the FDA to say, yes, this is what's evidence-based. And I think we have to really look at that critically as we move forward. The same thing when I showed you that chart of the REMS programs for teratogenicity are sort of all over the map. It's not based on reproductive endocrinology understanding of a cycle. And since, for example, many of these young women are on oral contraceptives, they may have a very irregular cycle. And so, even that comes into play. Clearly, we need to have strict adherence to pregnancy prevention for people who can become pregnant. We want these drugs to be used safely because we want them to be used because we think they're so important. So that's really, those are many of the obstacles which have unfortunately led to deserts of iPledge. And I have a colleague who's doing research in the Navajo Nation where there is no one who's qualified to give that medication. Which is really sad because these are deserts essentially of medical care. So I hope these technologic approaches will not only help, but will also make us say we need to modernize the entire conceptual framework that we're working in. That would be my ask.
Yeah, it's I appreciate the challenges you're raising here. You mentioned the 7 manufacturers. We talked about electronic health record vendors need to get on board, potentially 2, but it does seem like there could be a path forward if there were that level of engagement with bringing down the barriers to collecting data through a system like this, and then being able to, just as Dr. Kotis mentioned, being able to use the evidence you're collecting to see where REMS are working well and provide more confidence, and maybe at least test out a modification and have an evidence-based approach to updating it. Do you see, can this get going? What would help move this forward and overcome some of those significant current barriers that you described?
Well, I think a lot of what was described in the video, except it didn't show the prototype, what it would be like with all these pregnancy tests and the lockout periods and all of these things, which are really end up being the kind of sticking points of the REMS program and iPledge. Also, just let me give you another example. Someone changes insurance and you have to get another prior authorization for a new insurance company, and then that person gets locked out of the program because they couldn't get their medication refilled, so they're back having to wait another month, and those disruptions they're very time consuming. They're very upsetting to patients and doctors alike, and I think the technology, if it's really well thought out, absolutely will help. And we want to emphasize that. And one other wrinkle I wanted to mention, though, was asynchronous thing is to be paid close attention to is when the consenting is done. In an office, we can't have the patient sit at our computer station. That's, it's not our medical center doesn't allow them to use the same computer as me. So at UCSF, we can afford to buy iPads, but you can imagine in small practices, what are they going to do? It's really important to have workarounds that understand that patients may not be in the same place as you when this is going on. And even up to and including a paper form that can then be manually entered by someone or scanned, et cetera. This will happen with pregnancy tests too. We, as an exception during the pandemic, and we very much hope that this will continue, we have been able to use home pregnancy tests with photo attestation, a photograph uploaded. That's also really been a huge plus. So things like that should make it better for patients.
Yeah, now I do want to spend a little bit more time on what would make this easier for patient participation. And I want to do that first by bringing in Lane and then maybe come back to some of the iPledge applications and Rob, what this means for people with schizophrenia as well. But Lane, you described experience that was pretty good in terms of your access and having confidence that the right testing was being done, and that when you did have a complication, it was detected early. But you also mentioned that there wasn't a lot of transparency, I guess without the data being available electronically easily. What would you like to see more of as this kind of program is implemented? Is it more timely access to your results? Are there other things that you think would be helpful?
Yeah, thanks. Because I've been dealing with my own health situation for 10 plus years now, I am somebody who absolutely goes in and uses the electronic information systems. I've linked up a couple of the medical centers that I work with so they can see each other's information. And I was very surprised when I couldn't do that with the REMS testing. I was required to go to before COVID and the pandemic, I was required to go to Quest Labs, which I'm sorry to say don't have the best reputation in my particular area. But if I go to a Quest lab, I can then see online the results, but I couldn't connect them in with these other medical centers. You know, if there was some way to make it all connected, it would help me tremendously. I'm also knowledgeable enough about what we were looking for in terms of my test results that I could ask questions. The REMS testing, once it went to a mobile examiner, there was no way I could see these results. Sometimes the blood labs would turn up other curious things that I wanted to ask my transplant teams about. So it was really important for me, if I'm having the blood labs every single week, it would really be helpful for me to know that somebody besides somebody who's looking at it for an eye for specific side effects would also note the other anomalies and be able to talk to me about them. I'm somebody who really wants to know what's going on, you know, as a patient. So the transparency would be incredibly important.
Yeah, well, I think the evidence is pretty clear that patients who are more informed can be more effectively engaged, and that can lead to better outcomes too. And I appreciate how, with proper advanced planning, this approach could lead to facilitating patient engagement, asking the right questions, avoiding complications as a result. But Rob, let me first turn to you and then Ilona. So for you're dealing with a different population of patients, many of whom are not, in part because of their condition, in a position to be quite as actively engaged as Lane has been. Is there a patient side to this kind of prototype that could help in the management of patients with treatment unresponsive schizophrenia?
Oh, I think absolutely. And, you know, I think we, you know, for people with schizophrenia, I think they're often underestimated in terms of what they, you know, want to know about. And I think that, you know, I think sometimes the onus is really on us to sort of be transparent and to kind of show people what the labs are, what they mean, and then really encourage people to ask the right questions. Many of the families are really quite involved and really want to know about what all the labs are. I also think that the other part of this is that when somebody comes to the pharmacy, you know, and they try to pick up their medicine and the clozapine is not there, it can, if the patient has access to be able to view, you know, did the prescriber do their side? Did the pharmacist do their side? They can then contact the right person and let them know kind of if you know, where the problem went. Because right now they just contact me and, you know, and maybe, and, you know, clozapine, and I'm sure many of these other medicines, kind of a 24-hour job, you know, like somebody's at the pharmacy at you know, 5 a.m. on the weekends, you have to be able to figure out how that person needs to get their medicine. So I think that it can help to really narrow down where the intervention needs to happen, and, you know, can also help to reduce the burden on the work-life burden on the prescribers. If, you know, a patient can look at it and say, okay, it looks like the labs were, you know, the labs, they have access to the labs, just now the pharmacy needs to, you know, certify the labs, and that sort of saves me a call.
Yeah, it just seems like, in listening to all of this, while this prototype seems like a direction that everyone in the prescribing world and patient world very much thinks could help getting to that critical mass of adoption, and then making sure that the program works as intended, would really be helped by thinking from the start about how this can help patients in situations where they are having challenges with access and trying to build that in. And Ilona, I'd appreciate your comments on this topic from the standpoint of patients who are trying to work with you to manage their,
Right.
you know, very difficult acne. What kind of features might be good to think about from the start to encourage more uptake and to make sure these programs work as well as intended?
Well, I think that some of the sticking points that were outlined in that graphic that I showed really highlight this. For example, if for some reason a prior authorization was one of those dark lines that unfortunately we see a lot of, and partly because this medication is prescribed in certain ways because of the REMS program, very different from in other countries that don't have REMS program. We tend to give higher doses for shorter periods of time because of the burden of the program, which isn't really ideal for patients. So to decrease that burden would be really huge. So for example, getting locked out is a huge issue for patients. If there are a way to, even if they can't have a prior auth, if they can continue to do a negative monthly pregnancy test, so they'll never get locked out as long as for that group, the highest risk group, that would be a huge advance in the way that the program could be designed. So someone could just get a negative pregnancy test monthly and document that and never get locked out, so that whenever their prior authorization comes through, you know, you could see that all those green checks would then be there. That might be one example of something that could really, I think, help the program. Patient education. Another thing that I thought of as we were discussing this was, you know, when I go into complex systems, I often have a choice. I have a bot that I can, a chat thing that I can do a little chatting with, and it gives me my FAQs on, you know, that look at this, look at this. There's nothing like that in the program, that the REMS program we have right now, but it could be very helpful. And then, you know, the level of service of being able to get to a human being, if necessary, needs to really be ramped up. But I think that even the technology could bring in those sticking points and give you the common workarounds or where you should go next, et cetera. And that would be, I think, hugely helpful for patients.
Yeah, I mean, it does seem like there's a lot of potential here in your case. And you mentioned that your situation was more like Teralia, where, you know, where the patients really need to actively participate beyond just getting their blood drawn, but, you know, the pregnancy test certification, things like that. You mentioned, though, that there are some challenges that patients would face, even if there were an effective, like, electronic interface and maybe a patient-facing app that would enable kind of easy uploading or certification of pregnancy testing. So for those people who are in the access deserts, for those who may not have reliable access to the internet or a smartphone, any thoughts about how this program can work in that context?
I think that if it's straightforward, and if the majority of patients really have what we consider evidence-based attestation requirements, so that those who can't become pregnant are, say, every 6 months is the average, 7 months is the average course. So even a 9 month, so that some patients might do their attestation and really never need to be active in the program, but be able to, that's really one of the major fixes. And I think that we strongly advocate for that. And then for those who are in that very vulnerable group who can become pregnant, to, you know, to streamline, for example, there's a requirement that you have to have 2 forms of contraception, but if you do abstinence, then that overrides that essentially. But if there's any mismatch at all, it kicks you out of, you know, it kicks you into that waiting period again. And if there's some way for the system to let you know, last time you said this, and are you changing that? And if that, if that happens, but usually it's an accident, they click the wrong box because they don't remember what they said in the first place. So if there's more transparency through this technology, that's going to be huge for patients to be able to say, oh, that's right, I just clicked the wrong box, things like that. Because otherwise there's all the phone calls, and the call center has typically been very, very, very difficult to access.
Yeah, pre-populating data is something that's really helped a
Exactly.
lot of other apps
Exactly.
get off the ground. Rob, you don't have to raise your hand. There are only three of us in the panelists here, but do you have a comment on this or?
Yes, the virtual hand. So I guess what I was just going to mention is just how important the piloting phase of this project is, especially piloting among a very, very diverse set of practice settings, working with patients with different challenges. And I'm really glad that that's built into this rollout, is that piloting phase. And I think that, piloting also with all the stakeholders present, it needs to really be very emphasized with the new with the changes to clozapine REMS that happened in November 2021. It actually got all the different stakeholders together in a way to sort of address the issues that were going on. So some of these networks, I think, have already been building and are familiar with sort of how to interface with each other and how to have a positive collaboration.
Yeah, it's a great point, and maybe we only have a few minutes left, but there are a few comments. And I appreciate all the comments from all of our guests today, and try to work some of these into the discussion so far. But a lot of these comments go to getting to, I guess there's acceptable burdens on providers. I mean, we want to get the burdens down. It's a key priority in our, should be a key priority for our healthcare system right now. In terms of piloting, so we want to try things out and make sure they work well. And it sounds like, Rob, both you and Alona had experiences with the big shifts that took place where, piloting or a more sequential approach or feedback approach there would have been helpful. As these pilots get off the ground, what are the most important things? I'd like to get all three of you on this. What are the most important things that you'd like to address first? And for the prescribers, I think that might be the biggest pain points in terms of burden. What would be most important to build in from the start? I've heard things like, well, it's great to have this interoperability, but if lots of the labs that my patients are using aren't participating, it's not going to be all that helpful to spend time and effort on. So maybe that's one, but what would you all suggest? Rob, do you want to start?
Yeah, I think, a couple of things. I mean, first would be just sort of the diversity of settings and sort of samples in which the piloting occurs in the first place. I also think that, in the case of clozapine, just sort of getting all the stakeholders together, especially the external labs, the Quest, the LabCorps, those sort of places, because right now the model sort of assumes that the labs are sort of in the prescriber EHR type system, when in fact, I think that in some cases they're outside of that. The other things to sort of consider, like building this, is how do you think about sort of cross coverage situations and sort of transitions of care from inpatient to outpatient settings? Being able to override things at the pharmacy level, I think, would also be another important thing. Just in the case of an emergency and somebody needs a medicine, having the ability to override, and then also the system allowing for designees and that system to be fairly seamless.
Great, thank you, Alona.
Well, one thing that Rob brought up that I wanted to emphasize is some kind of way that if a patient changes provider, for example, how seamless is it going to be? So these would be things that would need to be in a playground environment for us to hypothesize that you changed from a completely different healthcare system. You had Kaiser and now you have UCSF Health or something like that. That, how is that? How does that work within the system? Because it's such a common thing. Delays in prior authorization, and is there some way that the system is resilient enough to allow you to put in some information? The synchronicity thing is going to absolutely be critical for the iPledge system. Asynchronous data entry for sure is a huge sticking point. So I think those are the diversity. I want to underscore that, because we have many doctors in different situations, different age groups. Also the patients who are in the group, for example, we treat rare diseases like ichthyosis with isotretinoin. Those patients are on the drug for really their whole life. So sort of how do they interface with this kind of system? And but they need to be considered because we're using these drugs for many different purposes.
Yeah, I mean, there's some great points about not just making sure the protocol itself is well designed and has a good plan for piloting, but making sure there's some critical mass of data interoperability and access to make it work so that it really can reduce burdens from the start and engage more clinicians and patients effectively. And your point about, we're talking about areas where there already is a lot of inequities in access. We want to bring up access, appropriate access through these reforms, but if we exacerbate equity at the same time, that's not a desirable result. And Lane, I want to turn to you for last word on this. Any final thoughts about what's really important from a patient perspective and patient interfaces as this protocol gets off the ground with the prescribers?
Yeah, again, I keep harping on the transparency and the sort of all of the data in one place if possible. But I think that's really important for the patient. And one other quick little comment, talking about the burden on the prescriber and the prescriber's office. And this is personal to my case. There was one person in my prescriber's office who would receive the data about my lab results and review them then with the prescribing physician. And then she had to alert me. If she were sick, if she were out of town, she called me from vacation one time. I appreciate her going above and beyond, but that is not good. That's, bottom line. But thank you very much for asking.
Great. Well, I want to thank all three of you for a great opening discussion about the path forward for this pilot program and for practical steps using interoperability to reduce burden. We're now going to take a short break and restart at 2:55 p.m. Eastern time when Dory Kim, who's assistant research director here at Duke-Margolis, will moderate our next panel. So look forward to seeing you all again in a few minutes.
Hi, welcome back, everyone. Now that we've heard about some of the key considerations for applying this prototype approach from the prescriber side, we'll be moving on to think through some of those same issues for the pharmacy setting. I'll start by introducing this session's panelists. For this session, we'll hear from John Simon, a patient advocate who was prescribed a REMS drug as a part of his cancer treatment. Michelle Kershaw, Senior Manager for Industry Relations, Strategic Product Management at CVS Pharmacy. Michelle Kidd, Senior Manager for Clinical Pharmacy at Credo Specialty Pharmacy. And lastly, Jennifer Martin, who's the Deputy Chief Consultant for Pharmacy Benefits Management Services at the VA. And now each of our panelists will have about 5 minutes for opening remarks. After opening remarks, we'll have a discussion with our panelists. So please do submit any questions, comments you have for the panelists at any point, or if you have a topic you'd like for us to address. John, will you start us off with your opening remarks? John, you are on mute.
Sorry about that.
Sorry.
I got a little practice there. So as a patient advocate, I'm going to kind of go through a little bit of my experiences as a patient and then some of my goals, from the experiences that I learned. I was diagnosed back in 2015, February 2015, with an incurable stage 4 follicular lymphoma. Although considered incurable, follicular lymphoma has an average survival of 18 years, with a subset of patients resulting in an early treatment failure. This subgroup, which I fell into, was originally titled the high risk for death group. I suppose they decided that wasn't a great name, so they later changed that name to progression of disease within 24 months. My pathway resulted in in a total of failing 6 lines of treatment in less than 4 years. In October 2018, my healthcare team and I agreed to try a non-FDA approved protocol in the hopes of bridging a couple of months to hopefully allow me the opportunity to participate in a yet to open follicular lymphoma chimeric antigen receptor T-cell clinical trial, which is a pretty technical name. I know Lori Adami is going to be following up behind me. She's actually gone through that process. The bridging treatment involved 2 drugs. One was obinutuzumab and lenalidomide, with lenalidomide being managed through REMS. The plan was to continue with the protocol until it failed. To everyone's dismay, the protocol has yet to fail. I continued with this protocol through March of this year, when we just made the decision to discontinue obinutuzumab due to some cumulative toxicity and pathogen risk concerns. We've continued with lenalidomide, and in July of 2022, I achieved a complete remission for the first time after, in essence, about 7.5 years of continuous treatment. The treatment plan going forward for me is to use lenalidomide as a maintenance protocol similar to what has become a standard of care for myeloma patients, at least for some docs, but having not yet been evaluated as a maintenance protocol for lymphoma. The maintenance treatment plan that we're going to do with lenalidomide is to continue until either my body can no longer tolerate it or there's a return/progression of disease. As a patient advocate, one of my goals has been to provide the data from my experience through a system similar to REMS, not only just to assess, safety and effectiveness and all of that, but also to subsequently guide standard of care for the benefit of all patients. At some point in time, it becomes necessary with the type of disease that I have to go into what we call trial and error. And it's the true for all follicular lymphoma patients. In my case, the timeline became condensed, resulting in a need to make educated guesses outside of the NCCN guidelines. And unfortunately, standard of care today is guided by your specific healthcare provider's patient experiences. So a lot of word of mouth. We are left to using our available resources, including, believe it or not, getting out and reading medical research papers, preprints, and seeking advice from our healthcare team in order to make decisions. In essence, we become the CEO of our body, and healthcare decisions with very little training and hard data or information. Standard of care is mostly guided by healthcare patient experiences via word of mouth, data collection and analysis via a system to guide standard of care and NCCN guidelines would be, I think, of a great benefit. And access at times is another issue. A lot of the things that go on with REMS, although tedious at times and inconvenient, are more nuisances from the patient's perspective. And was probably more of a manpower issue from a healthcare provider standpoint. But from our standpoint, we have to get, our access at times requires creativity, and at times, whether that be an insurance related, particularly, rules and out-of-pocket cost differences between a government-based insurance program and a private insurance program. From our perspectives, this causes a great deal of uncertainty. And unless the patient is persistent or is lucky enough to have a healthcare professional that fully understands the problem and the available solutions. For example, direct access, direct patient copay assistance. It's through a government-based insurance. It's not allowed. So you have to get very creative in figuring that out. And in my case, I'm on private insurance currently, but getting ready to transfer over into Medicare. Okay. That was it.
Great. Thank you, John, for your insights and sharing your experience there. Next, Michelle Kershaw from CVS Pharmacy will give her opening remarks. Michelle.
Yeah, hi, good afternoon, everyone. Thank you all for letting me have this opportunity to share with you. Just to reiterate, I'm the Senior Manager of Industry Relations and Strategic Product Management at CVS. My role focuses on healthcare industry standards development, including co-leading the NCPDP REMS workflow task group, government program compliance, and product innovation as well. Prior to that, I have about 20 years of experience in the community pharmacy setting. I was a bench pharmacist, field manager, and I also have some corporate experience managing the pharmacy workflow best practices as it relates to improving the customer and colleague experiences. So understanding that workflow process and making things as easy as possible for both the people behind the counter and the customer is something that's been top of mind for me for a long time. As it relates to REMS specifically, my experience with REMS as a pharmacist, it's definitely something that is cumbersome for the pharmacist. You have to exit your workflow, your regular fulfillment process, and go to another website to put in information, whatever is required that's very specific based on the product. And then you have to also be validating that all of the information that's required is actually completed. That sometimes means that the pharmacist ends up being a little bit of the middleman between the prescriber and the patient and the REMS administrator and the payer. And so it ends up being a little bit of a time-consuming event for them, which of course impacts their ability to take care of all of their patients, right? We want to take care of our REMS patients, but also everyone else as well. So the more we can streamline and integrate that process, the better it is for everyone, not just those that are receiving that REMS product. That kind of brings me to the prototype. I'm really impressed with the progress that's been made on the prototype and making sure that the prescriber has all the information that they need up front to be able to put that information into the REMS administrator's database so that that is all completed up front before the prescription even gets to the pharmacy. I think that's a huge win. It's going to mean that the pharmacist doesn't need to resolve those issues that come through from the REMS administrator when they go to do their validations, which of course is going to save everyone time. There are still some opportunities. I think that there's definitely some barriers where it comes to adoption. Other speakers have mentioned that already today. I just want to reiterate that adoption is critical. We can have a beautiful product, but if no one uses it, it doesn't do anyone any good. And also the other thing top of mind for me is thinking about the process itself. And with every enhancement that simplifies the process, you lose a little bit of the expertise that comes from doing it manually. So it's just a call out that something that is in my mind from my own experience and things that I've managed in the past, that making sure that you have that expertise to be able to answer questions, to be able to understand what is happening, is really, really important when it comes to being able to communicate with patients and providers. So really looking forward to continuing the discussion with everyone, and I will turn it back over.
Thank you, Michelle. Next, we'll hear from Michelle Kidd, representing the specialty pharmacy perspective. Michelle.
Hey, so my name is Michelle Kidd, and I am Senior Manager of Clinical Technology at Accredo, which is the specialty pharmacy for Express Scripts. And I kind of have that unique background to where probably about 15 years ago, I started with developing our REMS programs within our specialty pharmacy, and I was over that for probably a good 10 years. And then I'm transitioned into this position I'm in now, which is over clinical technology. So I have both the experience of the REMS aspects themselves and the manual piece that Michelle just mentioned just now, as well as looking forward and being able to see what those opportunities are and the technology that is being developed right now, and also the technology that's having a regulatory requirement associated with it, and hopefully be able to leverage those pieces so that we can reduce those manual aspects of the REMS program and help to streamline that so that it becomes more automated and just really transparent to all of the individuals that are associated with or are impacted, I should say, by the REMS program. So the prescribers, the REMS administrator, as well as the pharmacy, and most importantly, that patient. I know that we've heard earlier today from Lane, just as a patient, how she liked to be so involved with her own therapy and with everything that was going on with her, to the point where she was the mediator between the different prescribers that she had, so that she could transfer those lab values and things like that to all of her other physicians. And I really see from something like this that is being piloted, and hopefully, we develop, like what was said earlier, a foundation for an automated REMS process that it can get expanded on, as just a great leverage point for the patient to be able to take hold of of their pieces of care, as well as for transparency for the prescriber to be able to see what's going on with the patient and where that prescription is at in the process, and what their pieces are that they're responsible for, as well as the pharmacy being able to do that same piece and checking in to make sure that all the pieces that the pharmacy requires in order to dispense that REMS medication is fulfilled. And the other piece that I think this pilot and eventually the final product will help us with is that administrative burden. I found it so interesting when we were hearing earlier from our physicians that 1 minute, when it was 1 minute that was face-to-face time with the patient, equated to 1 minute that they were dealing with the REMS program. So hopefully this will reduce that aspect of that administrative burden, so that it will allow physicians to spend more time with those patients and be able to help them with the actual care of the patient and not that administrative piece.
Great. Thank you, Michelle. Last we'll hear from Jennifer Martin from the VA.
Good afternoon. My name is Jennifer Martin. I am the Deputy Chief Consultant for VA's Pharmacy Benefits Management Services. Under that umbrella, we really touch a bunch of different things. First and foremost is formulary management. So I think our system is really unique. We are the largest integrated healthcare system in the country. Our providers are our employees. We are our own payer. So we nationally develop our formulary standards and guidance. We also own and operate all of our pharmacies, and we have an integrated health record that ties all that together. So I think it's a little bit different of an experience than some of the others that we've heard from today. REMS is a part of our daily work that comes out of my office. It really ties a lot into our procurement process for drugs, because we are a government entity. We have some extra hoops and things that we need to get through at times to get access to medications. So I have Philip Strite, who's on my team. I know he's in the audience listening today, that really works individually with manufacturers when they have REMS requirements to determine, how to implement those. There are times, because of how our system works and some of the restrictions that we have as the VA, that we need to tweak at least slightly the commercial pathway for REMS products. A lot of that's on the procurement side, but there have even been cases where we've had to have manufacturers go back to the FDA because there's something on the form that just isn't applicable, or it's not something we can share, or we need to have that listed in another way, and really try to work those challenges out from the beginning before we get into the process. A lot of times the REMS process is tied to the procurement piece, and that becomes a challenge for us because pharmacy is the only one who's able to procure or authorize procurement of medication. So when the prescription form is on the same page as the REMS form, a lot of times we've got to do tweaking there. And I think pharmacy has really become the de facto gatekeeper for all things REMS. So those prescriber enrollment forms, patient forms, at most of our facilities, those actually end up coming into the pharmacy, because the person who's actually in the end authorizing for that prescription to be dispensed and paid for comes from the pharmacy. So I can definitely see the value to a platform like this and streamlining some of those processes, because there's a lot of pieces of paper right now that change hands. we are really pushing telehealth and other modalities as well. And whenever there's a new medication, I get the question, well, if we can't get the paper to the patient to sign, or, the provider's at a clinic that's 50 miles from the pharmacy that's dispensing, how do we get that there? So I think that this type of platform would definitely be beneficial. We have centralized management of a few different REMS products. It's interesting that clozapine was mentioned earlier. VA implemented a system where we essentially do all of the things that the REMS do, even up to the pre-dispense authorization, but we've built that into our electronic health record. It does all that adjudication internally. We've worked with FDA and the REMS administrator to be able to be allowed to continue that process, because it actually has some additional safeguards in place. And we're currently working with the REMS administrator to figure out how to get the data from our system over to their system and integrate that. It's been a challenge for us. I would say as a government entity, we have more restrictions about what can be shared and how it can be shared. And we've been working on this project for several years. I'm hopeful that we're getting to a point where we actually can move forward so that the VA information is available through the traditional REMS platform, but definitely some challenges, which I can talk about a little later when we talk about challenges and barriers. Another successful integration with a REMS where we've taken a more central management process with ambrisentan. We did a contract with the vendor for one specific product, and we sort of tied that in as well with a central push of data. So similar concept, but probably a different platform. So I'm interested to see how the platform transpires after the pilots and how to move forward. And I guess that's it from me for now. Thank you.
Wonderful. Thank you for all the opening remarks. On the next slide, we have some questions to kick off our discussion. As the prototype is being built to link the various stakeholders involved, how might integrating REMS within the pharmacy workflow using contemporary health data standards alleviate some of the challenges you're currently experiencing when you have to verify and dispense the REMS medication? So I think we covered some aspects from the opening remarks, but I'd like to dig in and focus on some of those potential benefits. Can I hand it over to you, Michelle Kershaw, to get a perspective from the retail setting?
Yeah, sure. So, integration is something that is going to create a seamless experience, not just for the pharmacy team, but also to help the customer as well. The prototype really focuses on having all of those REMS requirements completed before the prescription's even sent to the pharmacy, which, would be amazing for us. A lot of the time that is spent communicating back and forth with the patient or the prescriber for some piece of information that is missing. So that integration would be amazing. Additionally, you got to think about all of the different things that are going through the pharmacist's head while they're on the bench, right? So, they have regular prescription fulfillment that we've been doing for decades, right? But you think about in the last few years, we've introduced more immunizations, we've introduced COVID testing, we've introduced all these other facets of that pharmacy practice. And so all of those things are top of mind for the pharmacist. So integrating REMS into the workflow is relieving them of that burden of having to remember, like, hey, that's on my checklist too. Is this a REMS drug? Is this a REMS drug? And that will help them to be more efficient and make sure that they're being consistent and compliant across all of the REMS drugs every single time, which I think it would be great for them and for our patients too, right? We want to make sure that we're always dispensing under safe practices. So, in general, I think that's really where the benefit comes in. You're streamlining it, you're integrating it. They don't have to leave their workflow process in order to make sure that we're dispensing a medication safely to the patient.
That's totally understandable. Maybe we can go over to the other Michelle to kind of speak on the benefits of this from a specialty pharmacy perspective.
I feel bad for you. You have two Michelle K's, so you're navigating very well. from a specialty perspective, once again, kind of reiterating what Michelle said, is that, it streamlines the process, and compared to what we are doing today, for me as a pharmacist, I see this as being a more proactive approach to a REMS medication. So it allows us to go, we know this is a REMS, we know that we need to go to this program, or to the technology, I should say, and look it up, and we can see, because of the FHIR capabilities and the automatic population of the lab values, the pregnancy tests, everything that is required, that you're able to get hooks within the EMR and pull them to that technology. It will help to reduce that the outreaches to the prescriber, the confusion even of where that prescription is at, what's going on with the prescription. Has the patient even been educated? And I really see that as the pilot gets off the ground and items start getting built off of that foundational level, and taking feedback from the various individuals involved within the REMS program, within the whole community that's involved in the REMS program, the prescribers, the pharmacies, the patients, and the REMS administrators, the manufacturers. It's getting built in a manner that it's not really focused on one aspect of that REMS program, but it hopefully will serve all of the purposes that everyone needs. I shouldn't say all the purposes, and it's kind of utopian, but it's one of the things that, as things are built on top of it, it'll help to just allow us to go back to that patient care aspect for both the pharmacist, the prescriber, and really the patient, to be able to have that visibility into what's going on with their prescription.
Right. I mean, this is definitely going to be an iterative undertaking, and getting everyone involved and getting that back using this prototype for everyone. And I forget who mentioned it, building out the capacity and making sure that people are actually using it, and there's some incentives to use it, since everyone else is using it. Well, I think will be important. I know there's also Jennifer from the VA. Could you maybe speak on the benefits of this, and how this may help in on the VA side? And I mean, sounds like there's already been some extensive work at the VA, and also because of the unique positions, there's certain things that aren't as applicable to other health system settings. But maybe at least since we're kind of starting the conversation on using such a prototype, could you potentially speak on the potential benefits of utilizing a prototype such as this?
Yeah, absolutely. Again, because our health system spans the whole country and some of the US territories, we've got a lot of remote rural type clinics. I think a system like this really helps get that information in the hands of the correct individuals, instead of trying to email things or fax things back and forth. For us, one of the real benefits that I see is opening up access with dispensing. Right now, for a lot of REMS products, because the prescriber registrations or the patient forms are needed, our mail order pharmacies that service about 85% of our outpatient prescription volume really aren't allowed, or able, I should say, not allowed, that was the wrong word, but they aren't able to dispense REMS products through a mail order pharmacy, because it's really a fulfillment service. They don't have a way to go back to those individual prescribers or those medical centers to gather all of that information. So I could see that if a platform like this was in place, where they could just do a simple check and see, yep, everything's here, this prescription's good to go, we may be able to expand some of our mail order, which is really huge for us. We gain a ton of operational efficiency and cut down on cost doing it that way versus having the local medical centers fill it there. I think this also helps us with some of our telehealth programs. A lot of times a patient might be seen in a clinic that's 100 miles from the medical center that actually has the pharmacy that's doing the dispensing. And right now they have the challenge of getting all those pieces of paper back and forth and making sure they've got all the documents. So I can definitely see some utility there with some of our rural populations who are farther away from those metro centers that are actually filling the medications and doing that. And I just think getting the information all in one place and electronically verifying it is a lot easier and more streamlined than what we're doing now. I think there's just I'm not a fan of pieces of paper in 2020 anymore and having to file that and hold it and then track it down. So I think it just streamlines the whole process.
Absolutely. Sorry, I'm having. Okay, there we go. No, that makes a lot of sense. No, that's interesting to hear. I mean, the previous session kind of touched on how to reach some of those harder to reach populations, and the mail order and telehealth definitely are solutions to address those challenges, to be somewhat more equitable in access. I guess to go to the next question, so there are clear benefits to the pharmacy workflow for various pharmacy settings, but I'm sure there are some pitfalls or drawbacks to this approach. I think you one of the panelists, I'm sorry, I had it up a second ago. Some of the expertise is lost because you're not doing everything manually. I think that's kind of profound, and there's definitely some truth to that. So I wonder, in order for us to maintain some of those expertise as we're building this out and nothing falls through the cloud, do you think there may be some drawbacks to this approach so that we can kind of air those out right now so that we can take those into account as we're building it out? Maybe we can go over to maybe the same order. Michelle from CVS.
Yeah, hi. Yeah, I mean, I only say that expertise is an issue just so that we do exactly that and we talk about it, because if we are proactive in making sure we don't lose that expertise, we're going to be just fine. Technology is immensely important. Streamlining the process so we're more efficient and we can get the prescription in the patient's hand faster is of course our end goal. We just want to make sure that in that process that we're balancing the knowledge base too. So yeah, making sure that those educational pieces are in place, and that continues in perpetuity beyond just when you implement a new process, that someone that is brand new to the industry, 10 years from now, understands what that pop-up box means and their workflow process, right? What are we really trying to accomplish? Why is it important? So that they understand what their value is in completing that process, and the maybe one or two pieces that they do still need to manually data enter when there's 500 other pieces that they don't have to do anymore. So that was my purpose in bringing that up. Yeah, I don't think it hinders deployment of something like this. It's just something to consider as we deploy. The other pieces too are, adoption. A bunch of folks have mentioned that too. I think that's, explaining the whys to the most important stakeholders, understanding that this is an improvement in the experience, which is often hard to quantify. What is the extra few minutes of time saved? What is that worth to the prescriber or to the patient or to the pharmacist? What does that mean they can now do? So being able to quantify those things is challenging, which makes, obviously being able to support the business case to implement that much more challenging. So, I think those are kind of the barriers, but I think that they can be overcome with the right amount of research and preparation ahead of time.
Right. I know you mentioned that you're part of the NCPDP. Are there challenges associated with NCPDP or other stakeholder or groups that we need to consider to kind of build that adoption and building the case for, the use of this prototype?
I think those are forums where, the use cases can be shared and the business benefit can be shared. It's a large forum of folks from lots of different facets of the industry. And so you have sort of a captive audience in a sense to discuss those things and come up with solutions together. Michelle Kidd also helps support on the NCPDP side through specialty. So, I see it as a forum, not as another place or another source of barrier.
Michelle, maybe you can chime in and to talk about some of the barriers that or potential drawbacks on this approach and how we could address some of those barriers and adopting.
Well, yeah, and echo what Michelle said is that NCPDP is a forum, and it would be a great platform to be able to go and just educate and the various stakeholders on the importance and what this pilot and what this technology can do for us. Some of the we're going to have the same issues with adoption for this as we had when we started e-prescribing. And I'm old enough to remember before we started e-prescribing, and just think about all of the and even EMRs, think about all of the hesitation that was in the healthcare community about EMRs, e-prescribing. So I think we should take lessons learned and the areas of healthcare that were resistant to e-prescribing and really more the electronic medical records as our key, and like I said, our lessons learned from those types of implementations and adoptions, so that we can maybe focus on those areas so that we can learn from the past and really hope to try to get a faster adoption rate of something like this than what we saw really with EMRs. I was a hospital pharmacist when they started doing electronic medical records, and I have another background in retail pharmacy as a bench pharmacist as well. And so the resistance and the comments that I received as that staff level pharmacist about electronic medical records, about e-prescribing, I think we could really see some of the same type of resistance moving to this type of platform.
No, absolutely. Jennifer, I know that the VA is undergoing through some changes, and I'm sure the EMR kind of rings true to you. Could you maybe comment on the drawbacks or potential drawbacks of this approach and or pitfalls that we should consider as we roll this out from the VA side?
Yeah, and unfortunately, I think a lot of the pitfalls are on our side of things versus the platform. But as you alluded to, VA is in I won't even say the middle, I would say the infancy stages of doing a complete electronic health record modernization program. So we're moving from our homegrown system, which we have at, oh my goodness, I would say 130, 140 different sites. Everyone has their own instance, to the Cerner platform. So we've got Cerner up and running at 5 sites. And the plan right now is to slowly roll over to Cerner over the next 10 years or so. So already that's a challenge for us because it involves IT development in both systems to make something like this work. And we've had a lot of pitfalls just in getting Cerner to function the way that we need it to, because it's new and different and we're a complex system. As I mentioned in the beginning, our providers are our employees, we're the payer, we're also the pharmacy. So everything blends together. We have not sent much data out from VA. So while I think for a community health center or retail pharmacy, that data transmission piece is easy. There's nothing like that built for VA. We don't do that as part of our business model in most cases, because we are fulfilling those prescriptions internally. There's not an insurance claim unless it's on the back end for third-party billing. So I think, when I first heard about this, the first thought I had was IT development. I will tell you that's one of the areas in our system where progress is slow. even if I put a new service request in today to start to build in some of this functionality in both the Cerner system and our legacy Vista system, it may be a few years before that gets funded and the work's actually done. So we are not an agile system in terms of making big changes like that and turning it on and off. And there's a lot of players involved. So again, that's our own pitfall, but I think there may be other systems out there where it's harder to adopt something like this if they're a closed system and not transmitting that data. For us, the other piece, again, really ties into procurement of some of these drugs. Our team negotiates to get as many REMS or specialty type products as we can available through our pharmaceutical prime vendor, but there are other ones where we need to use specialty pharmacies and other venues to fill those, which is fine. My concern with a platform like this is that the provider may have the potential to do all the front end work and send it over to the specialty pharmacy for fulfillment. And that's a huge issue without our internal pharmacy being involved, because they're the ones that have to issue the purchase order and do a whole bunch of paperwork ahead of time before that specialty pharmacy can dispense. So we'd have to work through some logistics associated with that. And sort of on a related note, although our providers are all our employees, we've really expanded our community care network where we contract out for providers in the community. The rule of thumb is if it's a maintenance med, it comes back into VA for fulfillment, but there are some of these medications where that's not the pathway. So I can see some confusion there where our community partners may fill out the REMS information, thinks everything's okay, and not realize that actually it's non-formulary and they need a request adjudicated on the VA side and may just send it to that specialty pharmacy for fulfillment, not realizing that it actually needs to come to VA. So I think there's some challenges like that, at least from what I'm seeing, the platform itself doesn't address. I think we'd have to put some workflow and SOPs in place to kind of guide our providers, but little extra on the back end because we're sort of an all-in-one, shop for everything you need related to healthcare. So those were things that just came to mind right away for me as potential pitfalls for a system like ours.
Right. I think the training aspect is interesting, and definitely everyone needs to be supported and educated on the updated workflow. But is there just want to kind of close out this topic here. Is there any support that might be given for the pharmacy in implementing or piloting this that you may have thought about? I think the education piece is definitely one of them, but if there are other elements to make sure that the adoption goes smoothly.
I think that pharmacies are likely to be eager to participate. I think that, obviously there's bandwidth concerns with building something, as Jennifer mentioned. It's not, as easy as it might think. So that's a concern, of course. But I think the desire to integrate this kind of stuff is, important to all of the pharmacies. I think that the adoption or the desire to adopt is there. It's getting consensus that if we build it, you'll build it too. So I think that's maybe where the consensus building needs to happen. And again, going back to, finding those forums like at CPDP where we can share those ideas and get everyone on board with moving forward to pilot.
Yeah, and I want to also kind of piggyback off of that, because it's the way that this, it sounds like that this is going to be managed, at least for the pilot, is it's at the prescription level. So it's not even at the medication level. So it's that manual process that Michelle, you talked about. It's a hybrid, manual and automation. And you can't even say with this medication, you're going to do this all the time automatically, through the technology, I should say. And then with this other medication, you do it manually. It's literally going to be at that prescription level. And unless we have that adoption, like what you're speaking about, Michelle, it's going to remain at that prescription level. So it's going to be, and that's when it's going to be difficult on the pharmacy side and even on the patient side is when it's at that prescription level, because you're going to have to look up within the technology that's being developed every single prescription to see if it's within the technology.
This is really helpful. John, we'd like to close out the session with your input to bring it back, to bring the conversation to how it impacts the patient. I think, the pharmacy workflow is just one piece of it, but at the end of the day, the patient has to get their medication and have all the necessary education necessary to take it safely. So I just want to ask, based on this conversation, I'm curious if there's something that you would suggest based on your experience in obtaining and being educated on the medication, which you'd like to see in the newer versions that have a more patient-focused view. Just kind of curious. I know you mentioned ideas on the information that's collected may help inform the standard of care to kind of add to the body of knowledge, perhaps. But just wanted to get your thoughts on potential additions to kind of focus on the patient. Oh, you're on mute.
Sorry about that. I looked at the discussion question that had been sent out in particular and for a response. And what I've seen, and these are usually, some of these may be afterthoughts, but as far as delays in care, I think it was part of the question that was there. And I've experienced some of those. And I can theorize about some that potentially would be there as well. But the ones that I had is we changed, my insurer decided they wanted to change specialty pharmacies. And it takes an extraordinary amount of patient time and determination to get your drug on time. And sometimes that's not possible. Another one, which was has to do with laws, and I know we can't go changing the laws right away, but COBRA. I've got a drug that costs roughly $19,000 every 4 weeks. And you get the COBRA administrator and they're like, well, I don't understand what the problem is. You have all the way until September. So just, if you pay for it, and I just don't have an extra, 19 grand sitting around for 12, every 4 weeks for 12 weeks for them to get through doing their COBRA. There's also the transition from private to government. Some of that is starting to be addressed, it looks like. But this is something that's been in existence since 1971. Hopefully that gets addressed, because I go from, out of pocket of $830 per copay, which is paid through a copay assistance, to roughly $24,000 out of pocket by just transitioning from private insurance to a government insurance, would be Medicare. The last one, this is more of a critical need type of a thing, handling exceptions. And I know when writing these systems that, exceptions are not generally how you want to run your program, but when it comes to a critical need, such as compassionate use or right to try, does the system have a way, for instance, in my case, since it was not an FDA approved protocol, the insurance company said, fine, you're using right to try. It doesn't say, right to try doesn't say who pays for it. So insurance said they would pay for the lenalidomide, which was good because they have systems in place in order to do that. And the manufacturer for obinutuzumab, which was Genentech, said, we'll provide that free, okay? So the question I got is, let's say it was reversed. And now, BMS, Celgene has to be the one that's providing a REMS product to me. Is there a way through your system to provide for those kinds of exceptions?
Definitely the payment aspect is something to work through as it's all tied in. I know we're out of time. I'd like to thank all the panelists for a great discussion and their time. We'll have to wrap it up here. Now it's my pleasure to introduce Rachel Hendrick-Stirrup, the Research Director of Real World Evidence here at the Duke-Margolis Center, to facilitate our next discussion. Rachel, over to you.
Yes, thank you, DeRay. I'm happy to moderate our discussion, which will focus on health system perspectives. very happy that we're able at this point to build on great discussions we've had so far today on how the REMS prototype approach could work for prescribers and pharmacists. So another key element of this process will be integrating the existing health data infrastructure across and within. So thinking generally, for example, of how health systems might choose or even choose to select or build data infrastructure with various analytical and or automation capabilities that we talked about today to help clinicians implement the prototype for relevant and perhaps frequently administered drugs within their facilities. Also thinking about flexibility that is or might be needed within a health system's data infrastructure to accommodate the prototype. And importantly, thinking of how the prototype and its integration into current health system data infrastructure might affect the patient experience. So those are just a few examples of topics that we'll explore in this session, perhaps taking a deeper dive into what many have already discussed today around IT development and quality. So we're happy to have our panelists here to discuss this topic in more detail from the health system perspective. We have with us Lori Adami, a cancer patient advocate who was prescribed a REMS drug as part of her cancer treatment. Also, AJ Burnett, a pharmacist on the internal process control team at Intermountain Health. Also, we have Anne McGee, who's the director of the Center for Medication Policy at Duke University Hospital. And lastly, joining us is Diana Schreier, who's an informatics pharmacist at the Mayo Clinic. So now what I'll do is I'll give each of our panelists about 5 minutes for opening remarks. To start us off, I will turn to Lori Adami. Lori, take it from here.
Thank you and good afternoon. I was a cancer patient for 12 years, from 2006 through 2018, in continuous treatment with 7 different cancer treatments, including 3 clinical trials. It turns out I had the same disease John Simon has, which is follicular non-Hodgkin lymphoma. The first 6 therapies didn't put me in remission, but of course, all had difficult and in cases life-threatening side effects. In 2018, my 7th therapy, Yescarta CAR-T stands for chimeric antigen receptor T-cell therapy, or CAR-T, was a REMS therapy, and the only one of the 7 therapies I received to be a REMS therapy. Thankfully, Yescarta finally put me in a complete remission where I remain over 4 years later, and my oncologist speculates it may be a cure for many of us. Unlike most REMS drugs, CAR-T is not an off-the-shelf infusion or pill, but is personalized medicine or cell therapy. It takes the patient's own T cells, manufactures them at the pharmaceutical company's facilities to insert a target onto the patient's T cells, and then 3 weeks later, they're returned to the patient and infused. I was actually unaware that Yescarta was a REMS medication. In fact, I was completely unaware of the existence of the FDA REMS program until I was interviewed to participate on this panel, which I think is kind of astonishing given I'm very patient active that somehow I never was aware of the REMS program. I received Yescarta in a phase 2 clinical trial. As a participant in the trial, I received and signed off on a 30-page trial document which disclosed the potential side effects of Yescarta, which were extensive. All 7 of my treatments were at large academic centers. I received Yescarta at the facility where it was developed by a cancer researcher who then launched a pharmaceutical company to commercialize the product. Because Yescarta was developed at the facility where I received it, the medical professionals I interacted with had intimate knowledge of the risks that I faced, as well as with the mitigation techniques should I experience those risks. As a result of the efficacy of Yescarta, it is now being administered in non-academic research hospitals, distributed in hundreds of facilities across the US. CAR-T, which I received inpatient, is also now being administered outpatient, and I think in large part as a way to bring down the costs of the therapy. So patients will get their CAR T cells outpatient, and then they stay nearby the facility where they're being treated and go in regularly for blood work and health checks. Sorry, I just lost my place. While the REMS program is critically important, the burden on these smaller institutions is significant. Having a centralized REMS system would eliminate a large burden on each institution that administers these drugs. Currently, each medical facility is a silo, creating their own REMS processes. In addition, having a centralized system could allow for a feedback loop of outcomes where patients, medical personnel, and pharmaceutical companies could get a better understanding of what actually occurs with these therapies. So when they're considering a patient considering a therapy, it would be great to be able to see, well, gee, what are the potentials, risk, what are potential outcomes? Right now, it's a one-way street, so we cannot access the information. The types of risks varies greatly between REMS drugs. Take, for example, lenalidomide, which is similar to birth defect causing thalidomide. The REMS for this medication for women of childbearing age require ongoing pregnancy testing, birth control education and use, and ongoing patient monitoring. Yescarta is a different ball of wax in that the side effects that can result from Yescarta, such as cytokine release syndrome and neurotoxicity, can be life-threatening and render the patient unconscious, which happened in my case. I was in a medically induced coma for over a week after experiencing a dozen brain seizures on day 10 after my receipt of Yescarta. Also, cell therapies like CAR T are one-time therapies. And so really one and done, where the monitoring and the REMS procedures happen up front, but don't need to happen after the patient's, kind of gotten past those critical states. That's, different than REMS drugs like lenalidomide, which require ongoing for a patient that could be on the drug for a dozen years. As a patient, I would expect my medical professionals to keep me informed as to issues, risks, and mitigation approaches. And I'm happy to report this actually happened. If this information on the REMS program can feed into the patient portals that most patients interact with, that would be a benefit and could ease communication and knowledge. Of course, the demographic of cancer patients is that they tend to be older and perhaps less comfortable with technology. So any kind of system that's going to be given over to a patient will be better if it's made, usable within an existing framework. There can also be language barriers amongst the patient population, where English may be a second language. I am encouraged by the discussions today and hope that a centralized REMS system will result and streamline the current cumbersome processes that institutions and patients undergo. I also hope that all of the affected parties will be consulted as time moves forward and the project continues to ensure that the product that results has all of our feedback fed into it. Thank you.
Thank you very much, Lori. Now I will turn it over to AJ.
All right, thanks, Rochelle. So I work for Intermountain Healthcare. I've been here a long time. I've served as a community pharmacy director. I've been a hospital director. My current role is at a system level. It's called an internal process control team. What we do is we focus on medication compliance throughout the system. So our job is to ensure that we conform to some sort of standard, whether it be a joint commission or accreditation body or law, federal or state, the CDC, the FDA, and that includes our REMS medications as well. And I participated in several audits where the drug manufacturers come out to our sites and perform a REMS audit and see how compliant we are. And so that's provided some interesting perspective as well. So what areas do I oversee the medication management? Community pharmacy, specialty pharmacy, we have a mail order pharmacy, we have 24 hospitals, and we have just shy of 400 medical group clinics, all which use medications, and all of those participate in one way or another in REMS programs. So I would say that my perspective is pretty broad. So some of the issues that I've noticed, we've tried to perform a comprehensive REMS audit throughout our system just to see where we're at. One of the issues we have is the variation between the REMS programs. You have drugs like Rob mentioned earlier, Clozaril, where it's very comprehensive and so much has to happen just to get that drug. Well, then you switch and, you know, you go to our specialty pharmacy and you look at a drug like Sublocade, and really it's just a training that says, hey, I'm not going to send this to a patient's house. I can only send it to a provider for administration. Really simple. So it's hard to standardize that because there's so many different requirements for the drugs. Another issue that we see is just communication between pharmacy and providers. So you look at a drug like mifepristone, where, you know, you have to sign a patient agreement form. The provider has to register with the supplier. Then you have to document the serial number of the drug that you administer to the patient in the electronic healthcare record. And getting all that communication down, often our pharmacists are left just trying to scramble through the EHR and find where this documentation is. Then as I go from clearing St. George, Southern Utah, all the way up north into Idaho, we see that practice changes, and where they're documented isn't the same place. It might be in this section of the MAR in one and completely different in another, or they might not even be doing it. So the communication has been a little bit difficult. From a system perspective, it's hard to really own a REMS program when you don't have a really good repository to store data. And a lot of these drugs require very specific training. Like you look at Alvimopan, and it requires the provider to go through training. It requires the pharmacy and those members of the pharmacy team to be trained. It also requires those who administer it to be trained. So from a system perspective, you're saying, all right, well, who's in charge of that? Is pharmacy going to own all the nursing training, or is nursing going to do theirs, and physician leadership going to do theirs? Or how are we going to track all of this? And that's presented a lot of problems. And then just knowing, like, as employees move in and out and between help, settings, a nurse transfers floors, or a nurse moves in, or a pharmacist, goes to another hospital. How is that training tracked? And is there onboarding done for REMS? And how much attention and effort and energy do we spend ensuring that? So those are some of the issues that I've identified.
Yeah, thank you for sharing that. Next, we'll turn it to Anne.
Good afternoon, everyone. So I'm a pharmacist. I'm in the Center for Medication Policy at Duke, and I can certainly relate to everything that AJ just talked about, right? So in the Center for Med Policy, we are the group charged to write all of our internal policies, and then implementing any medications that have an ETASU, implementing those drugs into practice within our health system. So, we have to have those policies written because, as you've heard from a lot of different folks today, there's a lot of steps required within the REMS programs. And it's challenging, as AJ alluded to, because it's different from one drug to the next with what actually needs to occur. So I think, we write these policies. And then the other thing I want to make sure everyone's aware of is we work really closely with our IT folks because we have to build in prompts at the time that a provider is going to sit down to write their order, right? They need to be reminded perhaps that, yep, there's a REMS program. So have you done that training? Have you filled out that patient enrollment form? And then when the order then goes on to the pharmacist, we say, hey, don't forget you need to actually check, did the provider complete their enrollment, et cetera. So we have to work very closely. So we spend a lot of time with IT to build out that information and that detail into our EHR system. So it is exciting to think we may have a prototype that could potentially help with some of that with regard to streamlining some of the processes. So if we could have, I'll just call it a one-stop shop that outlines all of those requirements for each of us in that med use process. So the provider, when they go to order, pharmacist goes to verify. If we have the prototype and it can handle that one-stop shop to give us all of those prompts in one place, it would be a welcome treat. You know, we would certainly take anything to streamline some of that work process. The other piece of that is not always clear from one REMS program to the next. What are the requirements for the inpatient setting versus perhaps the outpatient setting? So when there's ambiguity, it creates confusion and a little bit of lack of confidence in our process. Like, what do we really need to have our staff do? So we need those to be very clearly elucidated. So I'm thinking if the prototype is going to prompt me with steps of the REMS process and it knows I'm in an inpatient setting, then hopefully it's going to help guide that a little bit and take some of that mystery out. Another thing I think about is training, which AJ sort of alluded to as well. You know, some of the REMS programs require annual training, some require a one-time training and you're done. So having that also clearly documented within a prototype would be helpful, just because we are doing that in a variety of different ways. But CAR-T is a good example, since Lori was on that treatment. You know, we have a variety of different CAR-Ts and a variety of different REMS portals that our staff then go to do their training. And then it's documented that they completed the training. So if the prototype could somehow tell us that nurses A, B, and C, yep, they did their training, it just allows us to not have to go to yet one more spot to look for information. And then the other aspect I would like to point out is also back to auditing. So if the prototype can allow us to use the data that's housed in the prototype to complete audits that third-party vendors are doing for the manufacturers and for FDA, to know that we are complying. And I think it would be really helpful to have the prototype from that aspect as well. So I think it's exciting. I look forward to the opportunity to actually see the prototype in an EHR, so that we can see what it looks like and how does it actually function and how does it tell us what we're supposed to do in order to make sure we're complying with the REMS. Because obviously we all come to work every day. We want to comply and do the right thing, but sometimes it's hard to know what we're supposed to do and when we're supposed to do it. So thank you.
Yeah, thank you so much. I'll lastly turn it to Diana.
Hello. My name is Diana. I am an informatics pharmacist at Mayo Clinic, and I specialize in clinical decision support and the medication management workflow as a pharmacist, so any like drug alerts, things like that. But most specifically, I've overseen our implementation of REMS drugs within our EHR, specifically building those out. And I would very much echo what AJ and Ann have pointed out with regards to especially the requirements for REMS drugs, particularly those that don't say anything about when a patient transitions to inpatient. It creates a situation where we're just making up what we're going to do. There's no REMS information to tell us what the appropriate thing to do is, and then it ends up the organization just has to decide what they're going to build out in their EHR, which I think is like one thing if you're going to build an electronic system to solve first, is like, what are those requirements, and, you know, list them out. Because again, we're just kind of, you know, flying by the seat of our pants in some of those that don't have clear guidelines, and we have to decide, okay, in this scenario, we're going to require this, but it's not necessarily clear. And if that will then be applied to every health system out there, I think that that would be an important thing to have clear for everyone. In our implementation, we've done a lot of what Anne had alluded to, is on every order that is a REMS drug, we have order questions that the prescriber has to fill out before they're able to sign the order. So they're all required. The other thing that we have on all of our orders is information about the REMS program. And we have simplified it such that a prescriber could read it easily and know exactly what they need to do. So on the sidebar of every order, we have a table that says, this is what you need to do at initiation of this medication. This is what you need to do for continuation of prior to admission therapy, which again, sometimes is a little, I don't know what we're doing there, but we're going to figure something out. And then any kind of variants or program requirements that aren't consistent across all patients. So what I will say, looking at the prototype that there was the video earlier today that we had all seen, I think the one thing that really stands out to me would be putting all of that information that's in the EHR with that drop down to select the patient and the drug, is integrating that within the order, because we know already that's where our prescribers go to look for stuff. Because they know, I want to order this drug. They might not even know that it's a REMS drug. So that would really be the place that we would want to have that information and have it be usable within the workflow so that they're not having to go to multiple locations within the EHR to fulfill this process. I think another thing that stood out to me as a potential and something that I personally find important from my experience as an informaticist would be a single sign-on option. So something similar to what we have with, for instance, the prescription drug monitoring program. I know those are all different by state, so we maybe don't all have the same frame of reference, but at least in the states that Mayo Clinic practices in, we have the ability to have single sign-on. So the prescriber can click a link, they'll automatically be logged into the PDMP website and be able to review the information for that patient. They don't have to enter in their login 20 times a day. They don't have to remember the patient's name and transcribe it over into another system. And I think that is a really critical piece to facilitate this process being easy for them, is having that be a single sign-on. They can easily access the information. And I think then the last thing that stood out to me is I think if I were a prescriber within the process, I would say that probably the biggest challenge would be knowing where things are in the process. I think a lot of people struggle if there's not a clear like point A, point B, point C, point D. So my other recommendation would be to, kind of like Domino's has their like pizza's going to be ready in whatever amount of time, which I think is actually time-based. I don't think it has anything to do with tasks being accomplished, but something like that. So like, if your patient called your office and was like, I can't get my REMS drug and I don't know why, that you would be able to go and look and you would say, it's stuck right here. And that would be the problem that we need to solve. So those are my biggest thoughts. I'll hand it back over. Thank you.
Yeah, thank you all so much. These are thought-provoking comments that you all shared from your pharmacists, pharmacy policy perspectives, all of which will certainly feed into our discussion now as a group. I heard a lot from you all about, what should be done or what we can do better or what's needed rather to move the prototype forward and other aspects of REMS. But maybe we can flip it a bit and talk about what is working currently or what are certain functions within the EHR or other data infrastructure components that actually are working or might be helpful to keep or perhaps leverage even more at this juncture in REMS implementation.
I can go. So one thing that I would say that we have right now that has been really useful to our prescribers has been pulling in all of the lab orders and all of any pregnancy test results, anything that's relevant to the drug, we pull it right into that order screen. So again, they know when they have a REMS drug that they don't have to search the whole EHR. If they just open up the order composer, they can fill out all of the REMS requirements right there. So what you already have shown is more slick than that, is that it's already in the form, which is even better. But I think that will really be a key thing that will be great for them.
Awesome. Any other thoughts, or we can move to the next question? Okay. All right. Well, what can be done, thinking about the, the prototype and piloting it, what can be done at this juncture to streamline the path to piloting or adopting the prototype for health systems? So thinking about streamlining, I know some of you have already given us some examples of, what would be helpful. So a closer look at what you've already suggested, or maybe just diving a little deeper into this, into your suggestions as it concerns streamlining processes and workflows within the system. What are your thoughts there?
I can go on this one, I think. So I think if you want to streamline it and you want it to be adopted, it's got to answer all of the requirements. Otherwise, we're going to almost increase the burden where we're going into this software to identify, these certain issues, but, it's not going to address the pharmacy requirements. Or one thing I noticed on the prototype was it didn't have like a wholesaler. So some of the drugs, you have to send stuff to the wholesaler, and they're kind of left out of the loop. So if I'm a pharmacist and I'm trying to validate that my provider that's writing for this drug is registered, and that's not part of the integration, now I have more work. I've got to go somewhere else to find that information. Things that we already have in place. So I think as complete a solution as we can make it would really streamline the process. Otherwise, it might just take longer and increase the workload.
Yeah, I would agree with that 100%. We already have to go in and out of different places, right? So we want that to be as streamlined as possible. That's why I was trying to call it, like, it really needs to be that one-stop shop, if possible, for as much information as possible to go in there. And then, oh shoot, I had one other thought and it just flew out of my head. So I'll come back to that if it comes back. Oh yeah, the other part about, we're having to call REMS programs sometimes, and sometimes when that comes up, the REMS program may be called, so may be closed. So if the prototype can be functioning 24/7, which is what I'm assuming it would be, and has all of that information in there electronically, then it allows us to stop having to have handoff processes, right? So that if when I'm leaving today, I tell my friend, because they're going to be here tomorrow, to take care of the rest of the REMS process. So again, as much of that information that can be handled in the prototype is great.
Yeah, good points. Lori, I have a question for you from the patient, or perhaps focusing on your experience or the patient experience around REMS. How might REMS integration better facilitate or even facilitate better interactions and experience with the health system as you navigate steps toward, receiving your treatment and being monitored for safety thereafter? What are some aspects that can be perhaps improved or addressed within the health system from the patient experiences around REMS implementation?
Sure. So the patient has tons of barriers put up as, you get this diagnosis, your whole life is suddenly flipped on its head, and you've got to overcome insurance issues. You've got to overcome getting to see doctors, getting additional opinions, and you got to go back to insurance, and you got to get more approvals, and you get tests done, and you got to call to get your results. So all of these barriers for the patient, potentially could be eliminated through a centralized system. So take, for example, when you get a scan done as part of, let's say I'm in a REMS program and I get a scan done. Right now, to get that result requires a meeting with your doctor. So the patient can potentially wait for days to get a result of something, which is really their information. And I think a lot of it has to do with the results being in disparate systems. So someone else commented on if you have to get a special lab taken through a Quest pharmacy, that may not roll up into your EMR that you have at your cancer center. So I think if REMS could truly get rolled out in a more global fashion and the patient would have access, because yes, the patient is fighting, but the patient is desperate for information. And anything that can be done to give that patient the information they need to proceed and to take out some of these barriers to advancing, I think would be beneficial.
Yeah, that's an excellent point. The more information the patient has at their fingertips to navigate the system in the event the system can't help them navigate, I think that would be one way to empower the patient in the process then, so that they could be their own advocate, or so that their caregivers can also be advocates for them if that information is also available to caregivers. So thinking more about the patient experience, and thinking perhaps, or maybe turning it over to, information being at the patient's fingertips for rather the patient providing information to the health system about this experience. I want to talk a little bit about patient-reported outcomes. Do any patient-reported outcomes or outcome measurement tools come to mind that could be helpful to facilitate the integration or implementation of REMS within the health system? Or what are your thoughts generally about incorporating patient-reported outcomes into this process?
There's this big concern called HIPAA. And, as an advocate for other patients, I've tried to make myself available as much as possible to other patients to help them as they go through their own medical journeys. And will encourage a doctor, if you've got a patient in a similar situation, I'd be happy to connect. And there's this concern and this liability risk about disclosing patient information. And so that's been a barrier to the feedback loop, I think, as well as obviously the institutions are very protective of their patient information. And, I've actually had the opportunity to visit the company that made my CAR T cells and visit with the employees who actually did the work themselves. And there's this disconnect. The patients are sort of kept in this separate group and don't necessarily have the interaction that might benefit the whole process and streamline what's being done. Does that answer your question?
Yeah, it certainly does attest to, again, your ability to empower one another through shared experiences, or understanding whether or not you have shared experiences or shared challenges that can be perhaps broadly addressed by coming together or banding together to communicate some of your struggles and challenges to healthcare providers or system administrators.
And I think social media has helped with some of this in terms of connecting the patient population to be able to say, hey, I'm thinking about this trial. Are there patients out there that have done that? We can do that, but that's just within the patient community. There's no feedback really between pharma and the prescribers and the patients. It's sort of a one-way street, ending with the patient. So, yeah, I'd be very interested, in seeing more of that, because I think it would benefit the patients ultimately, and the patients have the most at stake and the most skin in the game for all, for the process. So, yeah, I think that would be beneficial.
Yeah. Diana, AJ, Ann, can you think of opportunities, or do any opportunities or thoughts come to mind about better engaging patients in this process, or better engaging patients as to better facilitate the processes that you all have to, obviously work through and administer on a day-to-day basis?
I can speak to that a little bit. Within Mayo Clinic, at least, we maintain our own instance of our patient portal app that we've designed and developed. And I just have, they're mostly personal comments on it, since I too am a patient at Mayo Clinic, is On one hand, they do solicit feedback from patients, right? So I've gotten like 1,000,001 questionnaires from them asking me how my visit was, my promise scores, you know, just anything and everything. But the thing that has been disappointing to me after I fill those out is it doesn't seem like there's any feedback. Like you're just like sending it into the abyss and you don't really know if anything's happening. So I think that from that perspective, it's sometimes like challenging to like be excited to fill it in twice when the first time you did it, nothing exciting happened. And then I think the secondary thing that since I work in informatics and I'm like, oh, that looks broken, but there's almost never an easy way for a patient to report that the app's broken. So that I think that's another thing, is having a way to garner feedback from people who can see like this is not working, but I don't know who to tell. And also like I had a bad experience or a good experience, so that you can kind of build on that and you can say, you know, send it to your developers when there's a good experience so they're motivated, and if there's a bad one, figure out why that might have been and make it better.
Yeah, thanks so much for that. I'm glad you brought up the point about patient portals or other electronic ways of engaging patients in surveys and just direct communication and other communicative aspects. So Anne, did you have something to add as well? Or
Well, I was just going to say, I think as a non-IT person, the one thing I worry about from the prototype is whether if you had outcomes that were visible in there somehow, you know, what does that mean from a security standpoint, and what barrier is that going to present for us being able to, you know, implement and use the tool? And I don't think there's an answer to that. I think it's just one of those hypothetical things where patient details obviously and correctly make us all concerned about how a tool might be used or misused.
Yeah, great point. So actually, Anne, you might have something to say about this, but thinking generally about how data infrastructure can better facilitate health care system and communication within a health system, so that stakeholders who operate within it can learn from one another, as we just discussed how patients can learn from the providers and vice versa. What are some, or what are your thoughts on how this prototype might enable or support the concept of a learning healthcare system?
Oh, I think you could arm people with knowledge, right? If you put the information in there and it's clear and it's visible and they're not having to go search someone or find the pharmacist down the hall or page somebody, I think that is certainly an advantageous aspect to just workflow, and then just really feeling like I have the information I need to do whatever the step is I'm trying to complete, so that I can finish this order so I can get the drug to the patient, etc. So I really think it's just about, it seems like it allows people to be smart on their topic and move on.
Yeah, good point. Any other thoughts on that from our other panelists? How can this prototype help stakeholders within the health system learn from one another? Or what would you like to learn through implementing this prototype and stand to gain or hope to gain in terms of implementing REMS into your practice, or in your practice, and learning from, again, the implementation of the prototype as you engage with patients with various ailments or conditions that might warrant different pathways or might trigger different processes within the healthcare system as it concerns the administration of their treatment.
I think from my perspective, what I think implementation of the prototype would like make me most excited about is it helps people like see it in real life and apply it to what they have seen and kind of getting real life situations. Like, again, I'm a builder, so like my question is, how long is it going to take me to get these CDS hooks working? And I think that's like my main question, but the clinicians are going to be, you know, how is this going to change my workflow? How many places will I have to look? Will it be a one-stop shop? Will it be, you know, just another, you know, place for me to go to enter information and back and forth and back and forth? So I think from that perspective, the other thing I'm excited about is to see what end users think and whether they like the user interface, what opportunities they see for changes, just like getting it into the hands of people who are actually like applying it and have that clinical knowledge of having done lots of REMS drugs before, so they have opinions on how the future REMS drugs should be ordered.
I'm excited about just the standardization across a very large healthcare system. I think you have a whole lot more people with their hands on it and using it, and I think there's a you're much more likely to have better ideas, better ways to improve it if everybody's using it. And I think it would be really good for a healthcare system like ours.
Yeah, awesome. Thank you for sharing your thoughts. I have one final question before we turn it to our next session. So it is anticipated that you know, that the functionality of the prototype will be able to support REMS assessments. So do you all have any thoughts on ways that you can make your recommendations more visible in order to help developers iterate on the prototype over time?
May I clarify the question?
Yeah, so thinking of ways in which the prototype can be improved through several iterations at every stage, getting, you know, feedback on its design, on its functionality over time, and as it's, you know, piloted within the healthcare system. How might you want to better communicate your feedback, that type of feedback upon each stage of iteration? How would you prefer to communicate that feedback to developers of this, of the prototype?
I think at least using my informatics knowledge again, I think generally what we'll end up doing is like the waterfall project management methodology, where you build something, you implement it, you look at it, you build something again, and then eventually you land at whatever you're going to end up with. If it's something that people are really into, I've had good success with surveys, but of course you kind of need to know the person sending out the survey. So from my perspective, if we were to implement this at a health system, I think you would want to make sure that there within that health system is like a clinical leader who would be sending the official communications to people who would be using the prototype. Because I think then you get better feedback. It's like, I know Diana and we've talked before and she's always looking for things to improve. So I feel motivated to do this survey because she'll probably make, you know, something better, at least hopefully. And I think that that has generally worked better than just sending like automated emails or like fill this in if you get around to it, is having like a practice champion that, you know, it kind of sits in between. For us, it's like the informatics team and the clinical end users. But with this relationship, I think it would, you know, be your team, the informatics team at whatever site, and then the clinical team, and then having somebody from that clinical team be the champion of the project so that they can garner the feedback and send it back your way.
Yeah, excellent feedback. Thank you so much, Diana. Well, we are at time, and I want to thank all of you for this great discussion. You all provided, again, a lot of thought-provoking comments that I'm sure us and our audience will take back with us. So thank you again. That being said, I'll pass it over to Mark McClellan, who will facilitate our final panel focused on implementation considerations and next steps. Mark, back to you.
Thanks. My thanks too to Rachel and Dory and all of our panelists today. We've heard a lot about how important it is to address the goals of this prototype program for the REMS initiative. Integrating REMS with clinical workflows can be critical for achieving the overall goals of REMS programs, including through potentially significant reductions in burden and ways of engaging patients more effectively. So implementing this prototype effectively is a really important topic, and we're glad to have everybody engaging on it today. Our last panel is going to take a little bit of a bigger picture approach to this by trying to put together perspectives on all the input we've received. But this is also a good opportunity for those of you who are joining us today that have some further thoughts, ideas on how to enhance moving forward with the goals of this program, to please share those as well. And again, raise any final questions. I'm not going to try to summarize everything we've heard about today, but I do want to pick up on a few key themes, and hopefully that'll interact well with some of the comments you're going to hear from our panelists today. One key point is the need for attention to a thoughtful and sequential approach to implementation, with careful attention to not unduly add to the burden on healthcare providers and patients in the implementation of the program, and thinking about some ways in the short term where in this phase implementation, the program can help solve some pressing problems, some pain points around burden or ease of access. This comes to the fact that there are a lot of complexities that can arise anytime we change something as complex as our existing healthcare system, even if the goals and the long-term results may be beneficial. So a need for thinking about this transition phase, need consider supporting prescribers, pharmacists, and others, and how to use the new interface, and having some backups or contingency plans in case there are shortfalls or unintended barriers arising, and a need for engagement from all stakeholders, including labs, electronic health record vendors, REMS administrators, and the pharmaceutical companies involved in the REMS programs in the process. Among the key things that we heard about as ways to help with getting this program off the ground is planning for sufficient interoperable data as part of the initial implementation. That's going to be key for this effort, really reducing burden and not adding to it, and paying attention to data privacy and security issues in the process, and thinking about an effective patient interface, since there seem to be so many opportunities for patients to participate more effectively. And this program can provide more transparency and obviously help patients engage more effectively, and their caregivers engage more effectively in their care as well. Finally, two other points on the importance of addressing equity issues from the start, perhaps by piloting in a diversity of circumstances and populations, and the potential benefits of this program over time in using standard electronic data that's widely adopted and well understood as a foundation for developing better evidence related to safe use and the effective design of REMS programs. So lots we can talk about here. Those are just some of the themes that came up today. I'm really pleased to be joined by our four panelists who are each going to speak for about 5 minutes on some of their takeaways. And again, please contribute to Q&A if you have additional points to make. Danielle Boyce is a researcher at Johns Hopkins and caregiver for a child who has been prescribed a REMS drug. Kathy Graff is CEO of Sonora Advisory Group. She's here representing one of Sonora's clients, the National Association of Chain Drugstores. Jason Leedy, who's founder of Examoto, which is a UBC company, and Sean Mackey, who's chief of the division of pain medicine for Stanford Healthcare. So 5 minutes for comments from each of you to kind of talk about where we can go from here. Danielle, I'm very pleased to start with you.
Sure. So I'd like to just give you some patient perspective here. As you said, I'm the mom of a child who has taken REMS drugs, vigabatrin, for the better part of a decade. My Charlie had infantile spasms, a rare and catastrophic form of epilepsy. He was diagnosed before his first birthday, and he's now 12. Seizures have stolen his development to the point that he functions like an infant. However, vigabatrin is the only drug that has given him any kind of quality of life. And for some babies, it is a miracle drug that spares them Charlie's fate if taken quickly. This medication is known to cause peripheral vision loss in some cases, which is obviously not as bad as what would happen if the infantile spasms were left uncontrolled like Charlie. So this is a risk we're willing to take in many other families too. But because we're prescribed vigabatrin, we work with the REMS program. So in addition to being a parent of a child with a REMS medication, I'm also actively involved in the infantile spasms community. And I've known thousands of people over the years whose children have received this medication. A large part of my life over the last decade has been helping really stressed out parents deal with the challenges of the REMS program. We have been prescribed vigabatrin for Charlie by 2 different hospital systems, 3 different neurologists, a nurse practitioner, multiple insurance companies, and multiple specialty pharmacies over the years. So when I say I've seen it all, I've really seen it all when it comes to this program, at least for vigabatrin. There have been many times when the REMS red tape was more traumatic than the seizures. The cure was worse than the disease. We don't have enough time for all the stories. And I don't want to sound harsh, but I'm trying to get my point across as to the kind of barriers that could occur during implementation. I have told and heard thousands of stories, but what those stories have in common is a sense of disorganization. That's what these families who have never worked with their insurance company like this, let alone specialty pharmacies, let alone physicians, and there's an eye checking, requirement for the vision loss that's been waived for us, but parents report this feeling of disorganization, of balls dropped, and generally a team of people from multiple organizations who are not coordinating their efforts or bringing their A game. This is what I hear. I don't understand. No, I called this place. They didn't get the facts. This place didn't get the facts. That and calling around, and the parents just don't know what they're doing, but feel like they have to quarterback this whole thing. It's so disillusioning because it's the one time that you so desperately need our healthcare system to come together for a sick baby. And because of this broken system, the appearance is that nobody knows what they're doing. I'm not saying that's true. I'm just saying, everybody's trying their best, but I'm just saying that's what it feels like to live it. And it's shocking. So now you have a critically ill child and a new responsibility, which is to project manage this medication delivery, because if you don't stay on top of it, it won't happen. Or at least that's how you feel. So now repeat this process month after month. So you have to redo this every month. In my case, for 10 years or more, but 1 month is too long when you have a catastrophically ill child. I do want to leave some positive notes. One thing is that I have seen improvements over the years. Over the past few years in particular, we've had maybe 2 debacles per year. And by debacle, I mean you're on the phone 9 or 10 hours that week. I've only really had 2 like that this year, and that used to be a monthly occurrence for us. And this is anecdotal, but what I've observed are the technological improvements implemented by the key stakeholders in the process, particularly the specialty pharmacy. For example, sending text messages to me to alert me. That has been really a game changer because I have a sick child. Well, I have 4 kids, but in a full-time job, but I have a sick child. I do a lot of this stuff at night or, when I'm doing other things and I'm multitasking. It's really hard for me to be on the phone all the time. So just to get a text message to alert me that the medication is ready is a huge deal. And that didn't used to happen. So I'm not saying it's perfect, but it's gotten better. And so, the technological improvements in the workflow seem to be heading in the right direction. So what I heard today holds great promise to me that we can do even better and even greater things. So I commend you for what you're doing. I work in data standards and real world evidence. Like that's what I do for a living. So I really understand the value and how just the Herculean task that you're trying to pull off. My biggest advice is to tap into the stakeholders as you've done here in the patient community. Many of us are frequent flyers in the medical system, and we know what good programs look like, and we can advise you on best practices and what's not convenient. And just as someone else said, with an generally older population, they might have different technological response than our population, which are 20-year-old kids who do everything with these parents. They do everything on their phone. So, there's going to be different needs for different stakeholders. And I would definitely look into that. And then in terms of implementation, I would also say, when you're dealing with people in this situation, don't expect too much in terms of responding to surveys or dealing with anything that they don't have to do because they're in really a life or death situation. So consider that when you're you're implementing and looking for feedback, as well as when you're trying to use the data for other purposes. And there's governance issues and IRBs involved and things like that. Like anything that could possibly make it more complicated, I would just think hard about that before you add that to the mix. But otherwise, I'm really heartened by what I saw here today, and I really appreciate the work. I've been doing this for a long time, and this is the first time I really felt like this could really change for the better. So thank you.
Danielle, thanks very much for your thoughts. Really appreciate it. Next, I'd like to turn to Kathy.
Hi, this is Kathy Graff. Can you see? Yeah, there I am. Okay. So my bias is that although I'm representing National Association of Chain Drugstores, I've spent 30 years in standards development, primarily with NCPDP, which is the standards development organization for the prescription drug benefit. But secondarily with HL7 as it relates to pharmacy work that they have done. And I've been involved in the Codex REMS leadership team, as well as the public calls, and involved in some of the development work for this prototype that'll be piloted. And I have got to say that I think it is wonderful that we're building upon existing standards. We are not creating new standards. We are using the real-time electronic prescription standard that's being used today between prescribers and pharmacies. We are planning on using the electronic prior authorization standard that has been used for Medicare most especially, but is a new standard that is being used in the industry, as well as the real-time prescription benefit standard, which is a standard that allows a prescriber to know what drugs are covered under the person's benefit in a real-time environment by inquiring into the health plan of that particular patient. So in utilizing these real-time standards to get real-time answers in real time is really a strength of this program. And I'm very excited for the prototype because we are leveraging those standards that are already adopted in industry. One of the things that we've learned in the prototype work is that there is some diversity in workflow that is somewhat significant. A clinic or an inpatient setting administering a medication has different workflow for REMS than a physician practice might have. And similarly, a specialty pharmacy has different workflows than a community pharmacy has. So in my view, the prototypes need to, the pilots need to pilot in these various practice settings, because I would anticipate that we'll have more successful pilots in some practice settings than in others, and more work to do, and maybe different work to do, depending on the practice settings. So that's one thing I hope we can explore. They also will identify gaps, and that's a good thing. The pilots need to identify gaps. So the work, I think, of the Codex REMS project is really not going to be over with the prototypes. Secondly, adoption. I have been involved at NCPDP developing the first REMS standards that were developed over a decade ago, and they've never been adopted. And in fact, my work at NCPDP was surprising to me to learn that of all the standards that NCPDP has developed, which is over 20, there are a significant number that have never been adopted by industry. So we need to focus on how this prototype pilot will lead to adoption. And there will be a number of strategies that we need to employ in order to achieve adoption. And one of them might be looking at incentives. Someone mentioned earlier today the e-prescribing incentives that were available for prescribers back about a decade ago, provided by CMS in order to accelerate adoption of electronic prescribing. And we may need to look at incentive programs because there will be implementation costs for all the participants in this new program. So those are just some thoughts I had initially, and I look forward to our discussion.
Great. Thanks very much for those comments, Kathy. I appreciate it. And next we'll go to Jason.
Good afternoon, everybody. My name is Jason Leedy. I joined UBC 3 months ago, and I head up the technology, strategy, and innovation. In the context of this discussion in REMS, UBC would act as a REMS administrator. So I'll try to bring some of that perspective and some of the understanding from those type of operations to this conversation. I have been, and my colleagues at UBC have been involved in the design, build out, launch, operations of REMS of all sizes, retail, specialty, single manufacturer, multi-manufacturer, many ATAZUs, simple education REMS, et cetera, really over the last 15 years. So we've seen a lot of REMS designs, REMS constructs, how they bump up against the real world. Personally witnessed a lot of the challenges that some people have described here today, really hope and really hopeful that this standards-based initiative can really try to iron out some of those issues that we've all had and make REMS, less burdensome, more effective. And I think really, if you take a look at some of the comments, maybe AJ or Ann or Jennifer, talking about just the struggles, if you will, within one entity, multiple systems, different approaches in one geography versus the other, the challenges with IT lead times, development, et cetera. And then, extrapolate that over the entire healthcare delivery system in the United States, trying to implement a safety program. And you get an idea of the enormity of that challenge. And I think really the only way to meet that challenge is a standards-based approach. I think Kathy's right, not all standards get adopted, but there really is no other way to sort of solve this problem in the REMS space. So we're supporting this effort. I believe in Codex, and I would hope everyone here today that has a vested interest can support this effort as well. I learned a great deal today already, so just to thank all the participants and look forward to the rest of the conversation.
Thanks, Jason. It has been a great discussion. I really appreciate your contributions to it as well. And next I'll turn to Sean. And Sean, I think you may be on mute. So there you go.
Yeah, no, I got it together.
Okay.
Thank you, Dr. McClellan. I am honored to be here today. I've been impressed with the speaker's depth and breadth of knowledge and the expertise in these sessions. And moreover, I applaud the FDA and Duke for addressing this critical problem. By way of introduction, I'm the Redlich Professor and Chief of the Division Pain Medicine at Stanford University. I'm a longtime NIH and FDA funded physician scientist who cares for patients living with pain. And I care for them in a large, comprehensive, multidisciplinary pain management center. I'm also the creator of an open source learning healthcare system called Choir that we use at Stanford and other academic medical centers to help optimize patient care. I have no financial conflicts of interest. I was tasked by Thomas to think broadly about implementing this prototype and also future applications that build upon this terrific open source system. What helped frame these comments was to think outside of just the specific REMS applications mentioned today, and perhaps how this ecosystem could broadly be used to benefit prescribing both REMS and non-REMS related medications. And specifically, I'll put forward 4 recommendations that I believe, if enacted, could have a significant impact and help this. Recommendation number 1. engage the nurses in this implementation process. I talked with a number of nurses on the front lines that are dealing with prescriptions, and I learned so much about the operational challenges. I realized that despite running a pain management center that's very large, I didn't have an appreciation for what they're doing on the front line, the frustrations that they bear. And time doesn't allow me to cover all the challenges I heard them express. Many of the issues surround data validation resulting from having different systems, miscommunications in data between these systems, incorrect decisions when instructions are different around prescribing that exist in the clinic note, the EMR, and then yet separately in patient instructions, and many others. And it results in a completely disorganized communication. And I believe Ms. Boyce called this out just several minutes ago, and I want to amplify her message. Recommendation number 2. This is a future-related recommendation. Let's leverage interoperability and exchange of information to expand beyond non-REMS drugs. By way of example, there's a huge problem in society in caring for those with chronic pain who are taking chronic opioids. The past few years have seen an explosion of pharmacy denials to refill or even fill prescriptions for opioids with those with acute, chronic, and cancer-related pain. And I get the concerns that pharmacists have about potential culpability in opioid prescribing. But we have patients at end of life who are suffering needlessly, who can't get these medications for their pain control. This system could allow exchange of meaningful information to help address the pharmacist's concerns and allow smoother prescribing. That type of information that could be exchanged might be signed opioid agreements on proper use, negative urine drug screens, clean prescription drug monitoring program reports, as well as many others. We could also have patient education around safe opioid prescribing baked into the patient app. Completion of that education could be sent to the pharmacist and integrated as well. This is a big issue for patients, for pharmacists, and clinicians. And this is one I believe this system could really help solve. Recommendation number 3, very briefly, integrate it with prescription drug monitoring programs. As many of us know, the current interfacing with the state PDMPs is cumbersome, is time-consuming, and I'm being charitable. Recommendation number 4, integrate with the insurers. And I don't know if this one was mentioned. One of the nurse managers I spoke with just yesterday described spending 5 hours on phone calls the other day to get a patient approved for a pain medication. The problem is that the patient has multiple chronic pain conditions, 4 of them, rather common in our world, only one of which is approved by the insurer for this medication. Unfortunately, when the real refill came in, instead of forwarding the correct diagnosis that is covered, they picked one of the other diagnoses that the patient has but is not covered. That led to 5 hours of phone calls, the patient being denied and ultimately paying out of pocket for that medication. Integrating in insurers with their up-to-date formularies would be invaluable in helping to reduce the burden of prior authorizations, pharmacy denials, and subsequent patient and clinician frustrations. And then finally, in closing, as I mentioned, I led a team to create an open source learning healthcare system. And while the IT challenges are real, the operational challenges are orders of magnitude more important. And one of the most important lessons I learned is to make sure that we are giving something back to each of the stakeholders, something of value. I heard one of the other speakers talk about patient-reported outcomes, which we collect a lot of. If you don't give back information that is of value to them, you're just not going to get engagement. This has been a rich discussion, and I wanted to build on this and offer some of these recommendations for the FDA and the stakeholders to consider. I appreciate the opportunity to be part of this and look forward to future discussions. Back to you, Dr. McClellan.
Well, thanks, Sean, and call me Mark, and really appreciate all of your perspectives for this panel. We have one more slide, I think. This may be the last one for today that has some potential further discussion questions. I have to say, you all have already delved into very effectively in our limited time in terms of some recommendations and practical guidance for implementing the prototypes and ways to engage all stakeholders. And I appreciate your last comment too, Sean, about being intentional about what can be done in the short term of this implementation pathway to give back to the stakeholders and to help each of them find a path to engagement. And you've also talked about some of the longer term opportunities. We've had a few questions come in from participants, and I want to thank Claudia at FDA for answering one of them about essentially how the REMS assessments improvements or that have been part of PDUFA and have some clear goals associated with them fit with this initiative, and also Lauren for describing how this program is not taking the place of the REMS administrator being the system of record, but really facilitating those systems being developed as completely and efficiently as possible. There is one more, though, that I think we've answered yet that maybe is a good jumping off point for further thoughts about recommendations and steps to promote effective piloting and implementation, and it's from Jamie Wilkins, and it's addressed to prescribers, but I think all of you have talked about the topic of acceptable levels of burden in the context of severe adverse events. Any thoughts you have about, this came up in the earlier panels about challenges in the current system with prescribing in this circumstance and otherwise, but any thoughts on this topic? I know one of the key themes for the day has been the sense that the burden that we have now is substantial with the REMS programs, and a key goal should be from the start having some intentional steps to reduce at least some of those burdens.
This is Kathy. I would suggest that in the piloting of the prototype that we may want to include as a finding in those pilots some measurements of burden reduction. I don't know how those measurements might, there are people more qualified than I would be to determine how to measure that. But I think those measurements and measuring, documenting burden reduction as well as new burdens that we haven't thought of would be helpful in those pilots. And I think that would also serve to improve the work that we do moving forward, and going live, help to sell, if you will, this when it's time to implement.
And Danielle, you talked about a number of dimensions of burden in your opening comments.
Yeah.
Where would you focus first? What's the most?
Yeah, so I mean,
win?
It's tough because, I mean, the vigabatrin in particular, I mean, this is a very vulnerable population. This is, every second counts. So that not to say the others isn't, but this is a little different. It's a high stress, high stakes situation with infants. But one thing I would definitely do is work with someone like a group like the Child Neurology Foundation, who sees and spearheads things like the Infantile Spasms Awareness Week, for example. So there's a lot of initiatives around this, and Tuberous Sclerosis Alliance, for example, we all work with helping families in this situation. We've all heard these, or those of us who work in these groups. So there's already a lot of efforts underway, and have them help you to kind of stagger the implementation and the piloting. I mean, I might be willing to be a part of, to be the guinea pig, but I don't know that I would wish that on a newly diagnosed family where it's already so stressful. Like, I would know what to do if I didn't get the meds right away, or something happened, something went wrong, but maybe somebody else didn't. So I think it would be really helpful to work with a group that has that kind of expertise and do focus groups. This is where qualitative research comes in too. And I would do a lot of qualitative research before rolling this out with really vulnerable populations and stressed out neurologists who already have a lot on their plate.
Maybe a more in-depth look at a particular condition or segment of a patient population, and qualitatively play that out, tabletop exercise, something like that. Yeah. There are a lot of stakeholders involved here. Other thoughts, Sean? Please go ahead.
I'm sorry, I didn't mean to.
Go ahead.
Just building on what Danielle said, this notion of an iterative trialing process where you're kicking the proverbial tires and getting the stakeholders engaged in this, like getting Danielle involved. She's smart, she's thoughtful, but then, as she said, is she going to put in the risk of if something breaks? And so what you do is you give her a safety net. You give her a parallel path where if this system breaks, she's got an out and she knows that she can get the meds that are needed. Mm-hmm. Danielle, would that help put your mind at ease? If
yeah, 100%. Like,
yep.
Yeah. So when this drug was on label and a pharmaceutical company was running it, there was something called the SHARE program that I don't believe exists now, but it was extremely helpful. And we all knew it in the community, and we all knew we could call it on a weekend and somebody would scramble and help us. Now it's generic. So it's, so if we're generic, then it doesn't help us. But that kind of thing definitely put us at ease as we, like, let's say, switched insurance company. I hold my breath every month. If something changes, I'm like, what's it going to be like this month? Are we really getting it on Wednesday? Oh, I got the email. Is it going to come though? Like, that's how my weeks go, whenever we order Vigabatrin. So I think that, yeah, definitely that would be really helpful just to know, because if he doesn't get that, I mean, he could die from a seizure. So it's not, I don't really want to play, and help you experiment with the new program.
Yeah, thanks. Other thoughts about for these first couple of questions related to considerations for piloting and additional steps or watch outs to consider as the programs get off the ground?
Yeah, so I think as far as the initial pilot goes, I would suggest we don't pick a REMS that has such dire outcomes. I think there are REMS where, that might be a little bit more agreeable to what we're trying to do. I do really like the idea of a fail-safe process for participants in the pilot. So I think that's really good insight. So, maybe those that are participating in the pilot, have an exception at time dispense, and they can get their drug if things aren't in order. Pretty thoughtful, good idea. I would suggest in the first stage of the pilot, though, that we keep it small. There were a lot of ideas expressed today. I mean, the scope of what we're talking about today in its entirety is very large. I think the pilot should be very small. I think it should be focused on maybe one aspect of a REMS, perhaps an aspect of the REMS that would really exercise some of the technology. So by way of example, if we could have a single electronic health record, pull data out of its repository and fill out a patient enrollment form and submit that to the REMS, that'd be a huge victory and a good step forward. So my advice to the group would be, to pick something fairly small, something that's controllable, has value, but gives you line of sight to everything else that you could implement, so that you can then take that and build on it and put the other pieces in place.
And from your example of a patient enrollment form that at least in principle should include information that's already available in the electronic record systems of that institution, that's kind of an easier place to start than needing to pull interoperable valid data from multiple sources, labs, et cetera.
Yeah, and I think maybe pick a REMS where there's a step 2 to that dance. So pick a REMS where there's a patient continuation thing that happens on a monthly basis or some interval. Once you have established the ability to do enrollment, now we can take it to that monthly interaction, pull different data out, put it on a schedule, etc., and build from there. That would be my sense, in a way to kind of make it a little bit more manageable, give it a better chance of success.
Do others have additional thoughts on good places to start, steps that are relatively feasible in terms of delivering early wins in burden reduction, even if it's not everything that we'd like to see solved in burden reduction and interoperable data?
Well, I agree with Jason's point strongly about choosing a med or choosing something where failure is not going to be catastrophic. And I also like the notion, to paraphrase, I'm not trying to boil the ocean. Start very small and build incrementally.
Yeah, I like that idea too. I appreciate not starting with the most vulnerable population. I also think that when you're trying to put in this fail-safe, just allowing us to have 2 months worth instead of just so if you have to order it every month, that's where the stress comes in, because you are almost out of that med and like you have a little window, like 6 days, and then you have to reorder it. So that's where like most of my stress comes in, because when it gets screwed up, I could almost run out of medication and you're kind of trying to race the clock. So if you're doing that, then if there was a way, which I don't know, but if I had a magic wand, if there was a way to say, okay, the month before the pilot, you get 2 months worth of meds, so that if something happens, you don't have to worry about running out of meds. And I think that would make people feel more at ease as they switch over to the new program.
And I also agree that starting small is a good idea, and maybe even a certain practice setting, like a specialty drug in an oncology practice setting, for our initial pilot, and then build on that, rather than the iPledge program is a completely different program than an oncology administered in a clinical setting. So I would anticipate that those pilots could look different.
Yeah, so some great comments about starting at some point for this initiative and this achieving the goal of interoperability into clinical workflows and greater access to data and so forth. It's going to need to get bigger. So including lab results from maybe a broad range of systems, being able to interface with a diverse set of patient populations. As you think about moving from these first steps to the further steps, it seems to me that that's going to really take a clearer path for, as you all said, all of these stakeholders to see that the juice is worth the squeeze. This is going to be, while well intended, it's still going to be some work to implement and to get to interoperability and so forth. Any further thoughts you have about how to make a compelling case to get alignment and get broader participation as these initial pilots hopefully start to show some clear successes?
I personally would like to see an RFA and to get the academic research community involved in this and looking at the data, and groups like mine, for example, where to look at, to evaluate, to come up with plans for evaluating the program. And I think that would be very interesting, is to make this a rich data source, if you could, for process improvements and other things that go along with these diseases that are often understudied.
So what are some feasible questions that could really be answered with the standardized data that the REMS approach could help generate, both about the disease itself and about the REMS programs, perhaps?
Yeah, like we know that, how long you go from diagnosis of infantile spasms, for example, to a first-line medication like vigabatrin, influences your outcome. So we could look at that. This would be a great way to look at that, and other, symptoms, and also the vision loss question, which has been kind of controversial. How serious really is that? Would be interesting to study as well.
Sean, I know you've done a lot of work on evidence generation. Any thoughts about practical ways to make that more real?
Thank you. I was going to build on what Danielle said and ask her, Danielle, if you and your group got involved with this and really liked it, aren't you like the best cheerleaders for this type of system? Aren't you, because word of mouth from patients, patient advocates, spreads like fire. It's that's
absolutely. Yeah. I got my doctorate in public administration because of this. And now I'm a researcher because of the REMS program. So no, absolutely. And I would probably omapify it and go in that. So, right. So we would do a common data model and really get serious in looking at how to link this and, interoperably with EHR and, everything else. So absolutely. I mean, patients are the best cheerleaders.
Mark, as somebody who's been in government and had done this a long time, it's just in my more limited experiences that we go and put forward these programs, we build these projects, and then when they're done, the government kind of moves on. And I go back and some of the ones I ask, well, do you have a budget where I can advertise this and promote it? And they're like, no, we didn't factor that in. And so building in resources to like get the word out would be of help.
Yeah, it does sound like from all your comments, a key theme here is not viewing this program in isolation, but really trying to make sure it's aligned with, as we saw in a couple of the questions, further PDUFA expectations for REMS and a strategy for really improving safe access to TASU goals. And, on that point, Jason, I know you've thought a lot about how to make REMS programs work better. Any leading ideas about how REMS improvement could be a key part of the evidence developed here, or the implementation path?
Well, I think, and I picked the electronic health record and the prescriber and the enrollment on purpose, because it's sort of the first thing that happens in the patient journey in a REMS, from a REMS perspective. I also think that's a place where we can make some improvements. So traditionally in REMS, we don't really adhere to great design principles. We don't really do first things first. Sometimes we do the first thing last. And unfortunately, I think that's because what technology or what processes were available to us in designing those mousetraps. If we can move to the electronic health record and the prescriber and the beginning of the patient journey, we can probably design a better REMS as well. So not only could we have a better tech stack, we could just actually have a better process that we're enabling. So I think there's a lot of room for improvement there. A lot of the REMS at TASUs could literally be done up front. So, why send a patient who has all of these other stresses and all these other things they're dealing with? Why send a patient to a pharmacy who's ultimately not going to be able to pick up their prescription?
And
that doesn't make a lot of sense, right? I mean, we should get that figured out before we send the patient to the pharmacy. So those are some opportunities that are in front of us, I believe.
Related to that, I'm looking at the question that just came in from Jamie Wilkins, or really a comment, but appreciate any reaction. We're running short on time, but this is, for any future REMS or REMS updates that get put in place with the manufacturers, the REMS administrators, how would you suggest folding this protocol, this program into that? It should be a question that gets asked, how, to your point, Jason, about thinking about these implementation issues up front in light of new technologies and in light of an open source program like this protocol?
Yeah, so I think I understand what Jamie's asking in her comment. I had some similar thoughts earlier in the process. I mean, for those familiar with kind of building, designing, and then deploying and putting a REMS into practice, there's an entire approval process around that REMS. I mean, down to where's the button on the web page. I mean, it's to a very, very granular level. So to do a pilot sort of is outside of that general process, or how you would do a REMS as a whole. So, and I think the FDA, I'll leave it to them to comment, but I think they're participating in this and supporting this effort, would have to recognize that there'd need to be some other mechanism to go ahead and approve and put forth a prototype and get that working in the confines of a REMS. I think it would just be a necessity.
Great, thank you. Well, we are about out of time. I did want to ask if any of you have any final comments that you'd like to add, or last brief thought that we haven't been able to get to yet in this final session. I don't think we've covered it all. Danielle, anything to add?
No, I'm just so glad that we're trying to move away from faxes and, phone calls and the things that, it's just really heartening to me, as I said in my opening remarks, to see actually, these technological solutions, which I think are really going to be super helpful. And I just think about all the families who are going to be spared some of the stresses that, I've gone through because of this system. So I really appreciate it.
Well, we're not there yet, but I appreciate your support, not only for the vision,
it goes slow.
We may be able to get there, right?
Yeah.
Kathy, anything to add?
No, I would say me too on the reduced faxes and phone calls between pharmacies and prescribers and patients. That would be a big burden reduction in itself. So if we could manage that, that would be good.
Yeah, I think it's really resonating with stretch healthcare providers right now. Jason?
I would just say thank you to the Codex team. I think they've done a good job to date. I think they've had a lot of information to come through. I think they put together a pretty compelling prototype. And I would also just warn everybody that, you see a prototype and you almost feel like, next week we're going to have all of these things. There's a lot of work to be done, a lot of work. There's a lot of ground between prototype and the real world and getting everything integrated and working, but hopefully everyone's up to the task, and I look forward to it.
And Lauren highlighted in the chat this a next step piloting that includes, before you even get to real people and real data, a synthetic approach. And I think, making sure that your comments about including stakeholders and gaming that out and playing that forward and identifying some ways in which the phased implementation could really start reducing burden all seems to resonate. Sean?
I'm excited about the future potential for this ecosystem, the open source nature upon which others can take this code, can build upon it, can start integrating in other data sources, other data streams, and the types of problems that we can solve that not only include the REMS items mentioned here, but so many others that we're facing to reduce the burden on Danielle and her child and all like her.
Great. And, I want to thank you all. We are out of time now, but it's been a great end to a day that has had a nice combination of focusing on some really big and important goals, minimizing or avoiding serious risks of some medications while providing effective access, reducing burden, and in the end, maybe even engaging patients and their caregivers and families more effectively. Some big goals, but some practical steps to get there. The FDA vision for this stepwise protocol, the work by MITRE on an open source prototype and a whole implementation pathway around that, and then all the suggestions that have come in today about how to make that process work effectively. Just to repeat Jason and paraphrase all of you, there is a lot of work to do to get from where we are now to the vision, but clearly there's a lot of interest and a lot of potential for bringing together these different stakeholder perspectives and building on this process that FDA has laid out for implementing an interoperable, integrated approach to REMS that can ultimately truly achieve the goals of the REMS program. So lots of work to do yet, but a lot of promising potential here and a lot, I think, more clarity in how this can move forward, thanks to all the contributions of our panelists and really the whole audience. A very active Q&A with a lot of good back and forth there too. Before we go, I have to spend a few minutes thanking everyone who contributed to this overall effort, the speakers and panelists who shared their expertise and some heartfelt personal experience with REMS and how to make it better over the course of the workshop. Thanks to all of our colleagues on the FDA planning team for not only their efforts in this overall program, but making this workshop successful, including Gerald Delpan, Claudia Manzo, Edward Milliken, George Naira-Pali, and Mickey Hunt. Thanks as well to the MITRE team. A lot of work has gone into developing this prototype and all of the supporting processes around it. Nicole Ng, Lauren De Cristofaro, Sahil Malhotra, and Amu Urvaniti. And a big thanks as well to our team here at Duke-Margolis, Thomas Rhodes, Dory Kim, Brian Cantor, Nancy Ellen LaPointe, Rachel Hendrick Stirrup, Mira Gill, Nora Emmett, and Valerie Parker. And final thanks to all of you in the audience, all of you who are living with these REMS programs every day and are very committed to making them better. I hope you all have a great afternoon. We're very much looking forward to next steps in this important REMS work.